Welcome. Thank you, Sandra. Welcome everyone to today's meeting on the 7th of December 2022. It's lovely to see everyone. I hope you're all well. And again, my ongoing gratitude to all our staff for keeping going in very challenging circumstances. It really is appreciated. And could we start, please, with apologies, Karen?
Thanks, Chair. Apologies from Peter Drury today. Proxy is Donald McPherson. Apologies from Hayley Mearn and Emma Fletcher.
Excellent, thank you, and welcome, Donald, to our meeting today. It's lovely to see you. And Peter has his hand up.
Yeah,
Hi,
just
Peter.
say apologies. I had to duck out about 2:15. Be back about 3 o'clock. I'll leave everything on, but I'll turn them off. But I won't go offline. But I will be back.
Okay. Thanks for that heads up, Peter. Appreciated. And moving on to declarations of interest. Does anyone have any declarations in relation to the agenda today that's not already on your register of interests? I'm not seeing any hands. That's marvellous. Thank you very much. And if we move on to item 3 and the action log. So first of all, 3A, the minutes of the previous meeting. We're looking to approve these. Does anyone have any factual inaccuracies to flag up on those minutes? Or can we accept them as an accurate record of the meeting on the 26th of October? That's looking okay. Everyone happy to accept those? Yep. Thank you very much, everyone. And moving on to the action log on page 16. Just let me get there. And Gail, are you taking us through? Anyone?
I'm happy to go through them. Julie.
Okay, Gillian, thank you.
I think she's maybe just taking a call. Again, most of them are on track in terms of being on target and an amber status. Just to draw attention to item 6 on page 17, which was from item 6 on the 24th of August. That date has been changed to February next year, and that's to allow us to have some further discussion with the medical director and the nurse director. The other thing just to note is on page 18 in relation to the meeting from the 22nd of June, item 13, the annual performance report. We were due to bring back our mid-year report in December. And we have deferred that to February as well, just for assurance. It's not as a result of our capacity, it's based on the availability of the data nationally. And we will review that as part of the work plan going forward into 23-24 to make sure that we are bringing the most up-to-date and accurate information to the IJB. So we will review the months that it comes, but make sure that it doesn't have any impact on the annual accounts from Sandy's perspective. Just down at the bottom of page 18, I think we've got another red one. Sandy, I don't know if you want to come in around that one.
Yeah, Jill, both these two are referenced in the finance report, so they read more logically when you read them inside the finance reports. Hopefully that's okay for everybody.
That's great, Sandy, thank you. And in relation to the last one that's overdue on page 20, again, it's a long-standing overdue one in relation to the financial framework for the Living Life Well strategy. And there has been some progress, but just to note that it has been limited. And again, I think that's further referenced in Sandy's paper. Sandy, I don't know if there's anything that you want to add to that.
Yeah, Jill, just very briefly, you'll all be aware that different IJBs support different parts of our working when we're doing things on a regional basis, and one of the other CFOs is working on this alongside one of the NHS Tayside finance managers. So I am kind of reliant on them picking it up. There has been obviously capacity issues, and the progress is still limited. I think there are meetings due to be set up relatively soon to see if we can take this forward. And this is about the financial planning to back up the mental health strategy. So I hope by the time we get to our next meeting, we'll be able to say that something a bit more substantive has moved on.
Thank you, Sandy. I actually raised that at an NHS Tayside meeting, so it sounds like it's moved on a bit since that conversation. And I was going to pick up on item 13 to ask if there was a knock-on effect on the work plan, but I think you've probably covered that, Jill, unless Sandy has anything he wants to add in there.
In relation to
No,
the performance
doesn't-
report, Julie.
Yeah,
It will
yeah.
up when we review the work plan for 23-24, because we have to acknowledge the need for data for the annual accounts as well. But we need to make sure that we are bringing most up-to-date and accurate information to the as well. So I think we have a solution, and we'll include that as part of the work plan going forward.
Okay, thank you. Does anyone have any questions about the action log? Peter Davidson. Thanks, Peter.
Just a quick one. Thank you. Just to note, I suppose, my thanks and congratulations on some good progress across some of these actions. Many of them are complete, so just for the purposes of tidying the document up, I'd imagine now once they're complete and closed, it's the last time we'll see those ones on this particular action log. I always really like the action log on IJB. I think the deadlines are always quite succinct, but item 6, the support accommodation review, it says the item is closed, but a progress update will appear in the near future. I suppose does that contradict? Are we waiting for that project update? Is that an action or? But yeah, it's just whether or not the closed ones will now drop off the action log, just to reduce the size of that particular document and reflect the work that's been done.
Yeah. Okay. Who would like to come in on that, please?
I'm happy to come in on that. And well, Karen. Oh, you're on mute, Karen.
Sorry, I just didn't click far enough. Peter, just to confirm that generally what we do is when the action's been completed at the board, and going back to the next one, the completed action comes off at the following one, just so that it's there for reporting back after the previous meeting to the next meeting. It comes off thereafter. In terms of the item 6, what item was that again, Peter, that you said about the progress update?
It was the supported accommodation one, Karen.
Yeah. Yeah. The question was more relating to project update to IJB in the near future, as to whether or not we should have put a timescale on how frequent those progress updates were coming back or not. It may be a bit of a moot point, but.
Yeah, I think Peter. Yeah, going back to the 22nd of June one, item 6. Yeah, I think obviously we can certainly look at that and obviously bring forward a more updated report in future. It possibly should have a timeline, considering the fact there was an update to come forward. But we'll certainly revisit that one.
Lovely. Thanks for that clarification, Karen. Appreciate it.
Thank you, Peter. Anyone else got any questions on the action log? Can we agree it and move on to the next item? And thanks everyone for their work on that. That's marvellous. And moving on to item 4, which is appointments. And before we launch into discussion on that, just we've picked up an omission that will be addressed before the minutes are published as approved, which is the title of Dr. Andrew Thompson, that will be addressed in the final paper. Gail, your name's on this. Is there anything that you want to say to lead us through this briefly?
Sorry, Chair, my screen, I was getting a big backlash of an echo. Can you hear me properly?
You're fine, yes.
That's good. No, I didn't want to add anything else. I wondered if Andrew Thompson was online, not Dr. Andrew Thompson, legal Andrew Thompson.
That's actually what alerted me to the fact that the doctor was missing. Yes. I was confused about the Andrews.
I was looking for Lewis, but I'm sure I saw Andrew Thompson
join.
Oh, thank you, Andrew. Can you lead us through the paper?
Okay. Just bear with me. So I'm just having a problem with my PDF. 1 second.
Don't worry too much, Andrew, if you can't get to the right spot. I think everyone's had a chance to read the paper. There's just some kind of natural movement on it. All we're being asked to do is note the recommendations and I guess approve them. That Emma Jane has resigned as of the end of October, and thanks to Emma Jane for her contribution to the IGB. That we'll be welcoming Tracy Bowman as a non-executive director of NHS Tayside from the 1st of January, and we've met Tracy quite a few times now, really looking forward to working with her. Noting the appointment of Peter Davidson to the post of Vice Chair of the IGB, and noting that sadly Peter Burke has intimated his resignation as a non-voting member of the board and a member of the Audit Committee effective from the 1st of February, and we will be looking at getting someone to take over that role. In fact, tomorrow morning we're having a chat about that, so that's a loss, Peter, but we understand that people move on, and thank you for all that you've done. And noting that Peter McPherson, who's proxy here today, we've been informed by NHS Tayside that that role will cease, and that Professor Graham Martin is retiring on the 31st of December. And again, huge thanks to Graham for all his contributions to the IGB and the Audit Committee in Angus over the years. And noting that NHS Tayside's confirmed Andrew Thompson's appointed as proxy. And point 7, 2 vacancies have now arisen in the Audit Committee, and we'll be looking to appoint 2 members of the IGB to that role, excluding both Peter Davidson and myself. I think that's potentially something that we can look at once Tracy's in post as well, but just to bear that in mind, that we'll have a couple of vacancies there. So Donald, I can see your hand up now.
Yeah, thank you. I was surprised as anyone to find out that I wasn't going to be a proxy on Angus IGB anymore. So I have gone back to query that on the NHS side, and I think that's been a misunderstanding at that end. And the intention is that I will continue to be a proxy for Angus IGB. So
well, that's marvellous news, Donald. So thanks for that. And I guess that will be ironed out in papers forthcoming in due course. Yeah.
Chair, I can confirm, sorry, Donald, Chair, I can confirm that there is a report going up to NHS Tayside at their next meeting in December. So I think the next appointments report will come forward to our February meeting, appointing Donald McPherson as proxy for Angus.
That's marvellous. Thank you. Sandy?
Yeah, thank you, Chair. Chair, it's regarding item 7 on the bullet points, because that does note that we have 2 vacancies, but it does also ask us to try and appoint to those vacancies today if we can, because that will allow us to continue to function with the Audit Committee with a full membership. One of the members that we have needs to replace Peter Davidson. Peter has had to step down. I'm sure he's really disappointed about this, but he's had to step down from the Audit Committee because he's now become the Vice Chair. Peter was a member of the Audit Committee because he was one of the NHS members on our board. So really that post can only be filled by Peter or Tracy. And we know that Peter has, although he's not here right now, he has volunteered to do that, and Tracy is supportive of that. So hopefully, Chair, we could maybe agree that today and at least get one of the posts filled.
I'm very happy with that. Is everyone else? Yes.
Can I just get a proposer, okay, Chair, and a seconder for Peter Drury's appointment, please?
Sorry, Sandy.
I'm happy.
Sorry, can I just clarify? Did you say a conversation has been had with both Peter and Tracy?
Yes, Peter. Yeah.
Okay, thanks. Just missed that. Happy to
Happy to
propose.
do
Has
that,
proposed
Karen.
in that sense then, as long as they're content and are aware of this conversation taking place.
That's fine. Yes, I'm happy to second then,
Thank
unless
you.
anyone else has a burning urge to do so. Excellent, thank you. That's super. Well done. Really pleased to hear that. Okay.
Chair,
If we
sorry,
can-
can I just ask it again? Is there any other nominations just for the second vacancy, just at this particular time?
Not seeing any.
Don't see any hands up.
Thank you for keeping us right on process, Karen. Okay, we all
Thanks.
happy to accept those nominations and agree the recommendations on the paper. That's marvellous. Thank you all very much indeed. So on to item 5, around Tayside inpatient mental health services update. And before we progress into that, could I draw your attention to the wording on the second recommendation? This update has already been approved by another board, so we're being asked to support the recommendations detailed in it rather than approve them. So I'm proposing that we just delete the words "and approve," just for your information. Everyone happy with that? Yeah, okay. And if someone can take us through that, would that be Gail or Gillian?
Can I just check that? Is Jackie Pepper in the meeting?
Oh,
Yeah,
marvellous. Jackie,
she was-
sorry, I didn't see you there.
Yep.
Thanks for sticking your hand up.
Thank
So,
Can I introduce Jackie?
yes,
Jackie is the Chief Officer in Perth and Kinross Health and Social Care Partnership, and Jackie is the lead partner for adult mental health services. So Jackie has come along to speak to the paper, as you say, that has been approved at Perth and Kinross IGB. Jackie, can I hand over to you?
Thank you very much for that introduction, Gail. I would just like to say a few words before I go on to the paper. And the first thing is to clarify the lead partner role. And I know that that's something that you probably know as much about as I do in Angus in relation to primary care services. And we are in a similar position in Perth and Kinross in that the revised integration schemes clarified the difference between having operational responsibility for inpatient mental health services, learning disability services, and drug and alcohol services. From the and differentiated that from the lead partner role in relation to strategic or coordination of strategic planning, and I feel a bit like a broken record that I have to make that very clear in advance of any presentation, which means that if as a board you intend asking questions of me in relation to the detail around the inpatient services that are in this report, I would probably have to refer to others to be able to give an accurate and substantive answer to those questions. And also just to say that this was a report that was prepared for the Integration Joint Board in Perth and Kinross that met on the 26th of October, and I recognise some faces who were actually at that meeting. But since the 26th of October, things have moved on slightly again, and I can say a few words about that. But you'll see here in this report that it tries to update on 3 important areas in relation to mental health services. And covers inpatient services, learning disability inpatient services, and general adult psychiatry inpatient services, and is beginning to and not quite there yet, because it is still a work in progress, ensure that that oversight, if you like, that Perth and Kinross has also includes an update on community mental health services and how those services are progressing, but we haven't quite achieved that yet. I would just like to draw your attention to the fact that across the 3 IJBs and with NHS Tayside, we have together in collaboration supported the development of a programme team, a new permanent team to support the delivery of Living Life Well strategy and the transformation programme that flows from that. And there's a programme manager and 2 project support officers, 3 staff have been recruited, and they are now inducted and effectively engaging with a whole series of key individuals and key groups around a revision of the structures to support that, the programme structures, and as well as the areas of priority for the programme itself. It was intimated that kind of revision of the governance structures for what's Listen, Learn, Change, which is an action plan that arose from the independent report provided by David Strang, and the Living Life Well strategy would begin to become together, because when I took this role on in May, they were actually sitting separately, and very much the same people coming together with different purposes. So I need to streamline these arrangements. Was set out in this report, and the reasons for that. And I'm pleased to say that there has been some movement around that, with proposals which will come forward to the IJB in Perth and Kinross and to NHS Tayside board in due course around what the streamlining of that would look like. And it's very important that we ensure that Angus IJB and Dundee IJB members are involved and engaged in and are in broad agreement with the direction of travel. There is an overview in this paper around an update on the Listen, Learn, Change action plan, which has moved on further, and I would just like to give you a more updated position in relation to that, because the Tayside executive partners submitted a collective assessment of the delivery of their leadership promise that's set out in Living Life Well. And there was a 35-page progress report with a RAG rated status against the 49 recommendations for Tayside within the Trust and Respect report. That was provided on the 7th of October to the Independent Oversight and Assurance Group. There was a slight extension to the original date because of the demands associated with the death of the Queen and Operation Unicorn that flowed from that. The Independent Oversight and Assurance Group have provided a final draft report to the TEP, the Tayside Executive Partners. That was received on the 10th of November for the purposes of an accuracy check, and a response was prepared and submitted to the Independent Oversight and Assurance Group by the 22nd of November. A final meeting was held between the Tayside Executive Partners and the Independent Oversight and Assurance Group on the 30th of November. And so the anticipated date for publication of that report following approval by Scottish ministers is likely to slip slip further than the recommendation, as you see, set out in this report, which was to come back before the end of December with a written report on the detail of that. So I think that's going to slip into the new year. So I just really need to make sure that you're cited on that. And the report itself is likely to focus on the key issues as it's set out in the report from the 26th of October, and with a real focus on areas for urgent areas for improvement. And the revision of the priorities that are sitting within Living Life Well and our work in that. There's something like, I think originally when I took this over, there was something like 31 areas of focus and work streams. So there's been significant amount of work to reduce that down to originally 12 and probably down to 5. And those 5 will not come as any surprise to you, because these will be, excuse me a minute, I'm just going to get my right document up in front of me. These will be crisis and urgent care pathway, integrated substance misuse and mental health services, specialist community mental health redesign, which is the specialist community services, adult mental health inpatient redesign, and a whole system approach to the redesign of learning disability. So, and although there are other areas of work that need to be developed around practice change, pathways, etc., these are the 5 core areas that everyone connected to this programme board strategic leadership group are indicating are likely to be the main focus in the immediate and short to medium term. So that I hope brings you up to speed with where we are just now.
Jackie, thank you very much for that. And I guess I'm concerned around the timing of the report being published. For our reporting mechanisms, is it your hope that you get that in time to put through your IGB and then go to the other IGBs and NHS Tayside in a fairly, clear, short process?
Yes. I sense your anxiety around that because this is such a significant report. Although it's not our report, I think that it's the Independent Oversight and Assurance Group's report. They will be sending that on to Scottish ministers. It will be for Scottish ministers to decide what they do with that report and in what format they might publish that more publicly. So there's quite a bit of consideration needs to go into how do we ensure that we have all of the relevant parties connected to this and that we have the messages within that clearly laid out, and that there's a comms plan for both internally for staff and externally too. So, but I appreciate your concern about making sure that that's as streamlined and as tight as possible. So we need to work that through. Yeah.
Absolutely. Thank you very much. And I was also, when you listed the 5 strands, things like delayed discharges and the coming home report could easily be accommodated across a number of those in an integrated way. So I got that. Thank you. I've got Alison Clement and then Elaine Henry.
Thank you, Jackie. I welcome this discussion around the table around mental health, and we continue to prioritise it. And Angus, as you're aware, I just had a question. You have the strategic planning role for mental health. However, so much of our mental health services are codependent on aspects of the Angus Health and Social Care Partnership strategic planning, and I'm thinking prescribing, general practice, the community hubs, the third sector, the interface between physical and mental health. So I'm very keen that we are involved in the clinical community are involved in this. And I'm also noting, I think it was a report from the Mental Welfare Commission around future planning for mental health, around the need to involve the people who are treated by inpatient care in designing the services. So I'm really thinking around how we make sure that the Angus population and the Angus clinical community are engaged with this, because this hasn't been to our Angus clinical partnership as yet. So I fully support the need to prioritise single site model. Don't get me wrong here. I do think there's now a bit of work around starting to engage with the primary care and the clinical community in Angus. And for me, there are several aspects of living life well that need to be prioritised, and it's really how, you know, I'm not fully in support of deprioritising some of the living life well. And for me, the sooner we're able to develop the community models of care which support people well in the community, there will be, and the staff looking after them who are feeling very vulnerable, and there's a danger that we're prioritising inpatient here. For me, it's a chicken and egg situation. We need to get that bit right, and that bit needs to be locally owned and engaged with. So while I appreciate the role of P&K, I do think there's a bit of work now that we need to do at the next stage in making sure that the clinicians in Angus, and I'm talking about the psychiatrists as well, who haven't so far felt involved, that we get them involved and build up moving forward. So we're in a place where we can improve. We've got a lot of work going on, so it's just looking really for some reassurance around that.
Well, thank you very much.
Can I come in there briefly? Gillian has her hand up as well, actually was in front of Elaine, but I'm going to ask Elaine to come in, and then maybe Gillian can cover off some of those points with Jacqueline as well. Is that okay? Elaine next.
Thank you. So two reflections and one question. So I think my first reflection is it is great to see a report from one IGB being presented at another, and it's in response to the whole Tayside working. And I think that fracturing and that sense that a lot of innovation had to be done with the board, had to be done with mental health services, and then the 3 IJBs. So I think the fact that there is work across and we're having this conversation is really heartening for me. And I think this has to be how we go forward, because this is the only way we're going to coordinate our services and to maximise the resources we have. One specific question about delayed discharges, and I think what would really strengthen this document perhaps is to put on the length of time those people have been on as delayed discharges. I think it was described that when we started collecting on one electronic system, we had to actually take people across from the old previous system. And just probably reflecting, my sense are some of these delays are for years. These are many, many years. When I have the time frame in acute, if I have somebody who's been in for a year, that is absolutely a position we have to act on. But that's the norm for mental health, and I think perhaps describing that would give much more strength to it, much more power to it. And it's also probably an ask of communities to accept people back in from hospital who are members of their community, who have been in hospital and now need to come back to our community, their community, somebody else's community, but it needs to be acceptance that people can come back. Yeah. And my question really is about how, and it's an open question, how is the post-Strang, post-Lees landscape going to look? So how, and that's really an ask to the 3 IJBs and NHS Tayside, how are we going to organise ourselves when we move out of that point of scrutiny, reporting, directing, call and response from external scrutiny to how are we going to go forward as 3 IJBs, a health board, a national care board, because that is likely to be starting at the time we come out of this. How are we going to organise ourselves? And that's a question to me as much as anybody else.
Thank you. Would you like me to come up on Gillian's point?
I think if we bring in Gillian first, and between the two of you, I'm sure we'll be able to cover all these points. Thank you, Gillian.
Thank you, Chair, and thank you, Jackie. I think just to give IGB a level of assurance, and indeed the next report on the agenda is our update around the Living Life Well implementation plan in Angus. So IGB will be aware that we did bring an implementation plan back in June, and this is us bringing our progress report in December. And in relation to the key priority areas that Jackie's highlighted, We do have Angus representation across the work streams, so just to give a level of assurance that it won't drastically change what we're doing in Angus and what's on the plan. But if there are any changes to be made, then we will certainly incorporate them, but we will take a local and a regional perspective on that. And I think, again, just to give assurance to the committee that from a engagement perspective in the local plan, that we did extensive engagement, and I think, Alison, that did come to CPG from a local perspective. I know you're speaking about the strategic direction. So I just wanted to give a level of assurance around that and around the involvement of primary care to the IGB. And Elaine, in relation to your comment around delayed discharges, it's quite an interesting one, because some of the general adult psychiatry delays don't wait as long as what the LD ones do. We do have some, unfortunately, but the LD ones, we tend to consider and think about the LD ones differently for some reason. And I think that I really welcome the kind of whole system learning disability redesign. I think that in line with Coming Home, there's a lot of really good work that we could do collectively and working between partnerships as well, to be able to ensure that people with learning disabilities do have access to as homely a setting, and if they don't need to be in hospital, and how we do welcome them back to the community. So I really welcome that and happy to support that, Jackie.
Thank you.
Thank you. Jackie, do you want to come in?
Thank you very much, Chair, and thanks, Jill, for your update there. You've mentioned some really important points and answered a lot of the questions and made my job much easier. So I'll just add to that a little and say, Alison, I hear what you're saying there, and just give you some reassurance that this opportunity, I said I would come back to the IJB with a more detailed report by the end of March, and using this as an opportunity to say, okay, have we got the right groupings together? Have we got the right memberships? So there's an opportunity to engage in that in a different way. So if you would welcome a discussion, Alison, around that, and I'm sure Gillian would want to join that, happy to rethink that. I think it's an opportunity to refresh memberships of various work streams. So happy to be as inclusive as possible there. I also wanted to pick up on the issue around delayed discharge and the length of time, and the different sets of circumstances that are faced by people with learning disabilities and their complex needs, and what they require to return to what I would describe as inclusive communities in which they can live and a fulfilled life are quite different to others who may be experiencing, acute episodes of mental illness. So I think they do need to be treated differently and considered differently. And hopefully, as we bring forward further updates, we can see some of the particular challenges that face those different client groups. And I think the question, the third point, was a question around the post-Strang, post-Lees landscape, to use your language, Elaine. And I think there's a real opportunity here to work together on what that would look like, because you'll see in the report there's an intention to bring together chairs and vice chairs of IJBs along with NHS Tayside board members in a workshop activity into the new year, which is really about, so how does the integration scheme land, if you like? So that really is determining what will the landscape look like to ensure that yes, Perth and Kinross can take forward its lead partner role, but in doing so, it can only do so effectively if all all of the 3 IJBs are effectively engaged, as is NHS Tayside. So there are 4 key partners to that, to ensure that whatever we're taking forward has that buy-in, and that the decision making and where decisions and how decisions are taken forward, and how directions are applied in this whole arena. How do we work together on that? So we have an opportunity to actually create that landscape in a way that works for the people that we're here to serve. So thanks for that question.
Jackie, thank you for that. And I am heartened by this kind of refreshing approach since you've come into post, and seeing this move on. It's such an important area for us, and thank you for your recognition of that. I've got Alison Clement wanting to come back in.
Just for clarity, it was the Living Life Well that I was wanting to come back, and the wider Strang report to Clinical Partnership Group. It's the primary care mental health wellbeing programme, which is part of that. It's the GP funding that has been through CPG, but we've not had wider discussions around mental health, and I would very much welcome that to happen. We do have close links historically with one of our consultants who has been attending, but I think we do probably need to rely on general practice to be supporting a lot of the people that, if they're not in hospital, and that is of making sure we're building the future clinical models together. So we'll get going with that. Thank you very much, Jackie.
Thank you. Did anyone else have any more questions for Jackie? No, that's looking good. Lois, just got your hand there.
Yeah, thanks, Chair. Yeah, so I guess, I'm just taking in the report, what's been said, people's questions, which were really helpful, just in unpicking this. So in terms of this report, can just maybe in simple terms, what assurances then can be given to kind of those patients and those families that are currently kind of experience delayed discharge? I mean, all that's going on, what progress has been made, and where are we at? Just some clarity, please, because I'm just finding it a little bit difficult to, and amongst all the reporting and meetings and strategies and words, where we're actually at.
I think that's a very big question, Councillor Speed, and something that the Independent Oversight and Assurance Group has worked very hard and across the whole of Tayside, and worked, there's been a lot of observations, there's been a lot of engagement with and site visits. So I think the report that will come forward, and I will be pulling that together, will give you that level of assurance that you're looking for across those 51 recommendations that came from the Strang report, 49 for Tayside, 2 for Scottish Government. So I hope that what you will see is a level of detail within that will give you the reassurance that you require there. But the report's not finalised yet, so I'm not really able to bring that forward in publicly at this point in time. Yeah. I think just to also give you some information about, it's in the report in front of you today. We have actually taken forward the first session, supported by Norman Drummond and Columba 1400, which was a group of 10 people, 4 senior managers, 6 people with lived experience or carers of people with mental health and learning difficulties. And they're meeting again on the 12th of December. And when I take forward a report to the IJB mid-December, I've asked them to contribute some comments about how well that has gone. So happy to share that with you in due course. But the very first day was very very encouraging, and it was all about relationship building and leading this together, which needs to be a core aspect of the whole programme. So we're beginning to make initial strides in that, and I'm very positive about it.
Okay, thank you. I'll look out for that future report then for a bit more clarity then. Thank you.
Thanks, Lewis. I think we're all looking forward to seeing that report and moving forward with it. Is that everyone on that? Can we then go back to the recommendations in front of us today? So acknowledge the current position within patient mental health services in Tayside and support the recommendations detailed in the Perth and Kinross IGB report, which is Appendix 1. And then we can go into the next local step, if you like. Okay, everyone happy with those recommendations? Yep, thank you very much. And if we can then go on to the Angus implementation plan progress update around the Angus Living Life Well strategy. And I'm guessing Jill's going to be talking to this for us.
I am. Yeah, I am.
Thank you.
Gail Forrest is on in terms of some of it to talk to the actual plan itself. So just a couple of things just to highlight in terms of the report itself. This is our first progress report in relation to our local implementation plan around Living Life Well, and I would just like to draw the attention of IGB to the current position. So within 6 months we have been able to complete 28% of our actions, and I think that that's a really positive step forward, with 42% of the actions on track to be completed within the agreed timescale. We have had some actions that have been partially completed, and we've had to revise the timescale for completion, and that's for a variety of reasons. So the revised timescales have been included within the appendix, which is as part of the paper. I think just picking up on one of the things that Lois was speaking about, and it's something that we don't lose sight of, the fact that we're actually doing this for the population of Angus, and we need to make sure that what we're doing and what we're delivering meets their needs as well as ours within the financial envelope that we've got to work with. So again, just drawing IGB's attention to the fact that the financial framework, as we picked up on the action log, remains outstanding, but we are making some progress around that. So community engagement for us is really important, and that's an ongoing action for us throughout the whole plan, because we need to make sure that what we're doing still is meeting the needs, and it is what the population of Angus are looking for. I'm not going to say what they want, because that's a very different thing, but we want to make sure that we do retain that connected communities approach, and that where we can co-produce and co-design the services with the communities that we're working with. I think just in terms of the improvement plan itself, we have used Peter, I think if you're on, we have used the COSLA brag, for those that were on the audit committee this morning, so Blue is complete. And I'm just going to ask if Gail wants to come in and add any thing to the actual plan itself, and then happy to take any questions, Chair.
Thank you, Gillian. Appreciate it. Gail?
Thanks, Chair, and thanks, Gillian. Yeah, as Jill has said, I think we are in a really good position in Angus in terms of the implementation plan, with there's 36 actions in total, 10 of them are complete and 15 of them are on track, and the other ones, which is Jill has alluded to, which are partially complete, are looking for skills to be extended, and that's due to various issues in terms of either Tayside work or Scottish Government work not being completed to allow us to progress those actions in Angus. So we are in a really good place. Obviously the plan was approved back at June IGB, and the request was for that to go away and have the RAG status, a lead officer, and governance groups, and obviously measures as well. So that is what the plan shows you today from the June report. So we've included the measure, we've included the timescale with the RAG status, and also a little update in terms of the lead officer, the governance group, and any work update that we felt that IJB would want to be aware of. So there's nothing that requires immediate attention in the plan at the moment. Everything is progressing well within the governance groups that have their allocated actions against them. And I think that's really all that I think I need to kind of draw to your attention, but happy to take any questions, Chair.
Gail, thank you very much. And I should have said welcome to the IJB, and it's good to see you back in a position relating to mental health and well-being. So yeah, it's lovely to see you. Thank you. Does anyone? Oh, Gillian's got her hand up again.
Thank you, Chair. I think it was just, sorry, I should have mentioned when I was speaking in relation to the 4th recommendation of the paper, and what we're asking, and again, I'm saying it now so that we can answer any questions in relation to this specific recommendation, that for future updates we include it as part of our strategic planning update as a programme of work through strategic planning. So the next update would be due to come as part of that report in February 23, and we would be looking to see if we can bring some of the actual data as part of that report of the measures that we've now agreed. So just to draw Board's attention to that.
Okay, thanks, Jill. There's been a flurry of hands, so we can come back to that when we get to the recommendations. So first of all, Sarah, and then Donald, then George, then Gail Smith. Sarah?
Thank you very much, Chair, and thank you, colleagues, for your report. Really well progress with this important matter. I'm just curious as to how we are in a position of completion of some of the actions, and when I say some, I'm referring to section 1, elements C and D on page 39, and section 3, number N on page 53. I'm not seeing the translation of what we're planning to do, what difference we will make, the measurements, and how we've then quantified that those actions are complete. I just wondered if I could have a little more information, please.
I can come back on that, Chair, if that's okay.
Yeah, please do.
Yeah. Thanks, Sarah. I'll take them in order. Hopefully I've put them down on my pad properly. So I think the first one was 1C in terms of being complete. I think that was because of that was the NHS Tayside work that was to be taken forward under kind of listen, learn, change around what is it that the crisis centre or community wellbeing centres, as are now known, what they would look like, or what the kind of the main outcomes would be from there. So that work is complete. The work coming on to that, and in the update column is planning work for an Angus crisis. CWC is now underway, and that is sitting under the mental health and wellbeing in primary care planning group, which has been established. So there is work still ongoing, but the initial part of work in terms of working with our colleagues has been completed in terms of what that should look like across the board. So hopefully that gives you a little bit of information around that actual 1C and why that is marked at complete at the moment. I think the next one was 3N, was that right? Bear with me 2 seconds, so I just scroll through. So that was the support, the development of the new pathways. So as you'll see in the update, all the pathways in terms of perinatal, ADHD and EUPD, the work has all been completed, and it is just at the moment that it's just to commence the actual work, but the work in terms of pulling the pathways together has actually been completed. And was there one other, Sarah?
There was, but in terms of the responses you're giving, the additional information is welcome, but I'm not assured it's really answering my question. I aren't assured that these are complete. I understand what you're saying, that some of it requires work with other partners, but I'm concerned that if it reads as complete, how do we track and monitor the ongoing work and progress to meet the ultimate ambition? if it's recorded as complete.
Thanks, yeah.
Sorry.
Carry on, Terry.
Yeah, hi, I'm Terry. I'm a service leader. So for the Mental Health and Wellbeing in Primary Care Planning Group, I'm the co-chair along with Lisa Prudhomme from Primary Care. So the work for now, we've got the business case. So that action was about the business case. So we've got the business case. So now the action for developing that, sitting with the Primary Care Mental Health and Wellbeing Group. So it's come out of this and it's gone into the other plan. So it is going ahead and it's being monitored, but it's just that part's done.
Okay, thank you.
I think there's something, Chair and Sarah, that we can take from this discussion around how we can cross-link to give that level of assurance that's required. And I think just noting in terms of 1D, I think that was another one, Sarah, that that you had raised, and that is an error. Actually, that should be green. I think we had agreed that on a call following comments from Alison as well. So we will take that back and ensure that that's updated.
Thanks very much, Jill. I'd welcome that. I think for me, it's more about when we look back on this, have we got the transparency to say the things that Terry's just said that help us conclude that the action is complete because it was the business case that was the action. So thank you. Thanks very much. Welcome that.
Thanks, Sarah. I've got Donald next. If you can, you've disappeared. Oh, there you are. Okay, Donald, thank you.
Thank you, Julie. My question is a similar theme, I suppose, to what Sarah has just been asking, and it was in relation to item 5 around leadership and culture, where item A we're showing is complete, and we're planning to develop a shared vision and culture across staff, and it seemed to me that there's an awful lot more to developing a shared vision and culture than simply holding a few sessions. And I just wonder whether there needs to be more around testing of whether people actually do share that vision, whether they all have the same culture. So, I mean, leadership and culture is notoriously difficult to pin down. And I just wonder whether we can really be assured, based on the evidence that's there, that one is complete.
Yeah, I'm happy to pick that one up, Chair, and thank you, Donald, for a good question. So in terms of the linkages, and I know Jackie's just been on speaking about the wider pieces of work and listen, learn, change as well, and there is an overarching action and recommendation from listen, learn, change about culture. So I absolutely agree. Culture is not something that you can action plan. It's not something that you can fix overnight. And the sessions that were held in Angus have been extremely successful, and we can demonstrate that through some of the iMatter results and the Pulse survey results as well. So happy to include that as part of the data when we come forward to bring in a progress update in February back, if that recommendation is approved by the IGB. So again, I guess it links back to that is the action that we had agreed, and how we monitor that will be how we actually assess the impact of those sessions. And that's part of the KPIs and the quality indicators around the actions and the measures.
Yeah, okay, thanks. I think it's important to see those pulse surveys that you mentioned to give that validation. Thanks.
Thanks, Donald. You're right. It's hard to quantify where a culture works, but everyone knows when it's not working. So thank you. George.
Thank you, Chair. Listening to some of the excellent discussion, I'm happy to come in at the very end. Mine's is basically on a typo, so I'll leave mine for just now.
Okay, thank you. Okay, Gail next, and then Elaine.
Yes, it's to continue on the theme from Sarah and Donald. Donald, I led the culture session for IOG on behalf of the chief officers across Tayside. So you're absolutely right. Some of the measures and what makes a difference remain very transactional. And I think we need to get away from that and really look at the learning that we've all learned from the independent oversight group, or we're in danger of replicating that situation. So I won't go over all of the areas that I think we could identify improvements, but there are many examples where we need to decide who we're making a difference for. Is it for the staff or is it for the patients? And when we say things like more people will be active, that's not helpful. So I will also take on to have another look at this, because I think there's definitely further work and lots of learning that we can take on here.
Thanks, Gail. Okay, Elaine Henry, you're next, please.
Yeah, thank you. And I think it probably just describes the difficulty of such a big action plan, and there's also sometimes a subconscious bias that we want to complete them. And I'm just perhaps reflecting back some of the learning from Listen, Learn, Change and from Strang is that often we can become task-based rather than that longer term view of being able to do something, evidence and learn and keep it going. And I suppose it probably is an ask that some of the, and just reflecting our early conversation, that a completed action is then taken off the action log as we do for this meeting. But some of these are longer term and there's an immediate action. I suppose it probably is then an ask that a completed action, if it has a ongoing monitoring or an assurance that needs to be given, that action and that ongoing next step is captured in the action plan. Difficult to know how to do, and I think absolutely echoing Sarah's point about how do we get assurance that what we've done is actually what we think we've done and we're still doing it. So it probably is just how do we capture what we've done? Is it still working? Is it the right thing to do? And I suppose just is that ask that this retains a live document, because it is until 2024. So again, that aiming to have everything completed very quickly may not actually be the best way to drive forward that correct services for the people of Angus and the people of Tayside.
Okay, thanks, Elaine. I'm going to ask Lois and then Terry to come in, and maybe Jill would like to kind of or Gail would like to round up on some of the discussion we've had. So Lois first.
Yeah, it was just seeking clarity with regards to the equality impact assessment. And if that's kind of accurate, just kind of picking up on the back of what Elaine just said there about this being a live document, and the quality impact assessment showing kind of like, yeah, no indication that there would be any kind of impact on people with protected characteristics. But then when you look at the report, and if I just give an example in terms of for older people's mental health, specialist mental health services for people over the age of 65, and I guess them all shown amber. So yeah, just to seek some clarity around that and the impact assessment, and if that is it fully completed.
Okay, Jill.
Thank you, Chair. I don't know if I want to add anything to that, but take your points on board, Councillor Speedon, in terms of the working document that we have said that the plan is. We said that for the EQIA as well. So if there are any concerns from that, then I would be happy to pick them up offline and look at to see how we can improve that going forward.
Thank you. I absolutely agree that a quality impact assessment should be a living document, not just a one and done. And when things move to implementation, they need to be looked at and refreshed and attached as they come forward. Terry, do you want to come in there?
I was coming for someone else, but I suppose for the quality impact assessment, I think we do probably need to review that a bit more carefully now that we are partway through, and give it a bit more attention, which we will for the next time we bring a report. But I suppose I just want to come in with the culture, because I think it's such a difficult thing, because I suppose it does look like if we should complete it, we think we're done, that we don't have anything more to do, and that's never the case, because that's an ongoing thing. But it's also that balance between giving enough information to show what we're doing and giving too much information. So even from my service alone, we could talk about the staff surveys for our new models of support for enhanced community support, for the 7-day service, the staff survey about our improvement plan. the sessions that I personally went to, all the teams to discuss any hot items, any challenges, the care opinion. So it's like, it's really difficult to get that balance right, but totally take on board when you really need to put more evidence in there, because maybe we've not put enough. But it's a balance between what's enough and what's too much. You end up with a very long document.
And you know, I was really heartened by, you know, the prospect of a workshop across all 3 IGBs. I think, you know, all these interactions that deepen partnership are part of that changing culture, and we have an opportunity being part of that, to strive for the best possible model, the best possible culture, because that will improve life for the people that we're providing services to, but also to staff who work in the services. And that partnership is utterly essential if we're going to address, you know, the top 2 risks in all our registers around finance and around the workforce challenges that we're all dealing with. So I think that's absolutely critical. Right, before I bring in Gail, I'm going to ask George what his typo is so that we can get that done and dusted, and maybe Gail can round up so that we can move on. George.
Thank you, Chair. It's actually 36. It might be my understanding, but I'm sure somebody will correct me if I'm wrong. And the table entitled risk. It has residual risk, likelihood 4 times impact 4, risk scoring 3. This is a very high level. 3 doesn't sound very high to me, and I think 4 by 4 doesn't equal 3. Is that a typo, or am I missing something? It repeats below, and I think down a couple of pages down.
Right.
I can come in to answer that, Chair, if that's okay. So it's a typo, Councillor Meehan. It's just in relation to the way that we report the risk. I think it was part of the risk session that we had, but I'm happy to share the actual table behind that for you.
Okay, thank you.
Thanks, George. Gail.
Yes, thank you, George, for your eagle eye there. That is well spotted. Yes, it's just I want to thank the IGB, because actually the purpose of bringing this report is absolutely to review and scrutinise the progress of Living Life Well and the implementation plan of what we're doing to date. So thank you for your scrutiny to this, because the last thing we would have wanted is for nobody to ask any questions. However, what's clear to all of us is it is still at early days, and I wouldn't want us to sign things off as what we've said. So I'm not quite sure about the completed actions part, but we can go back and relook at that. There's also a lot of other areas where I would like Gail and Terry to discuss the draft report. So I'm wondering if it will be ready by February, because it will still need to go our clinical partnership group and our other groups for support and sign off around the recommendations and a bit of work. So I suppose we're asking that the next update will be in February, but I think it would be a different update that we would put in February. So I'm not quite sure we'll be ready at that stage with this type of report.
Okay, I see Jill's wanting to come back in.
Yeah, thanks, Gail. And it was more just a progress update rather than a full update on the plan, Gail. So it would be a paragraph in the strategic planning update, because I'm keen that we bring this into this kind of strategic planning agenda, because it is it is a Living Life Well strategy. So that was the thinking behind that. But take on board the comments from today that have been helpful, and would be happy to not bring it back as part of the SPG if the IGB were looking for a fuller update next year, possibly April or June again, with the level of information required to be able to provide that assurance, and then we can look at the future reporting thereafter.
Okay, when you introduced the paper, Jill, I said we can come back to that recommendation, and having heard you know, the feedback from scrutinising the document, I think there's a level of interest that suggests we might still need a separate report on this rather than integrating it into the strategic plan at this stage, if that's all right.
Yeah, I'm comfortable with that.
I guess it's such an important service area that I don't want to see it disappear into everything else. But with that argument, I guess everything else could be separate as well. Everything's important, but I know there's a lot of scrutiny on this, and I think we need to continue to give it the attention that it's needing. So if I can go back to the recommendations on page 35, we've heard Gail say that she thinks we've done our job today, which is good, reviewed and scrutinised the progress of the plan to date, accept the risks detailed in the report, acknowledge the financial framework to support the strategy remains outstanding, but we heard there's been some progress on that, which does give me some assurance. And 4, we're looking to continue progress updates as a separate entity as we go forward, with a kind of update in February, but not the full report. Is that what you're saying, Gail? Yeah.
Well, we're due to bring a full mental health update in February anyway, as per the action log, Councillor Bell. So
sure.
What we could do is we could do a summary as part of that report, and then look to see how we can bring a fuller report back, possibly June, and that would be a year. And if there's any exceptions that we need to bring to IGB's attention, we can do that prior to the June meeting. And then it would be helpful as part of when we're reviewing the work plan, just looking at what we have to bring back around mental health, because a lot of the things in the full update are very operational now, given where they are. So hopefully once we've had the IOG report and into next year, we can look at the reporting for mental health.
Excellent. Well, I'm happy to support that approach. Everyone else okay with that as well? Okay. So Karen, if as long as you've got all those notes, I think we can accept those recommendations as amended and move on to the next one. And thank you everyone for your contributions, to Jill, Terry and Gail for that. I appreciate your contributions there. Okay, so if we can move on to item 7 now, which is a prescribing management paper. Gail, got your name on that?
Yes, I'm hoping Michelle Logan is in attendance. Can we see if Michelle is here?
Yeah, I can see
I'm
her.
here, Gail.
Oh, thank you. Yes, I would like to bring Michelle in to start off with the update here, and Dr. Alison Clement, I'm sure, will add to that as well.
Thank you, Chair. Thank you, Gail. I'm assuming everyone's had a chance to read the paper. I just want to draw attention to a few points of progress and change that we've had in the last 6 months since we last reported to you. We have been able to get some additional project support in the last 6 months. It's allowing us to have more robust working group measures around tracking our progress with our prescribing management than we've maybe previously had. That group is meeting monthly, and it's allowing us to do a bit more proactive management of our prescribing, look for things that might be coming on the horizon that possibly in the past we've just not quite had the infrastructure to do. So I think that that's some good progress we've made probably in the last 6 months. We are continuing to make a focus on our social prescribing, and also we have newly appointed members of staff for nature prescribing, and we're really keen to keep our focus on that and keep investing in that, because we know that that is one of the ways that we can reduce our prescribing on medicines, if we can encourage people into more of these alternatives to medicines. But I think we do have to acknowledge that although at the moment we do have a bit of an underspend, a cumulative underspend, we have got a forecast that looks like we will be overspent by the year end. We're running about 5 to 6% above the Scottish average at the moment, so I suppose we can't hide away from that. But we do have a lot of plans in place. From now, really running till the end of June, we've got practices engaged with prescribing incentive schemes. You can go out and look at patient groups, areas of high cost, really robust reviews of all these patient groups, in the hope that by the time we report again, we will have made some inroads into that potential overspend that we have. Cognizant of the fact it's quite late on in the year when we got out the incentive schemes, we have given the practices a deadline of the end of June next year to give them the chance, because we know that the GP practices at the moment are under quite a bit of pressure. So rather than them feeling they can't engage with projects if the timelines were too tight, we've given them that little bit longer to work on that. So I'm hoping that that might pay some dividends by the time we report next. There are a few areas that we know are pressures. You'll see in the report we've got emerging high costs. I think we mentioned this before, probably around Buvidal. You'll all be aware it's a initiative that the Scottish Government are very supportive of. Buvidal's an alternative to the more traditional opioid substitution therapies that we have, mainly methadone. But we do know that it is a little bit of a cost pressure that will be emerging, I think, into the year. But we're going to be trying to work, the prescribing management group in Angus are going to try and work more closely with the service lead for ADARS, just to look at how we manage that. And I think we probably do need to look at it in a wider scope than just the medicine spend, and see if we can start working on how this might actually reduce hospital admissions, visits to ED, nursing time, community pharmacy time. So I think it's a bigger picture than just the medicine spend, but it's just to highlight that we do have it on our radar. Other than that, I think the report's relatively self-explanatory, but if there's any questions that anybody has or anything that they want to pick up on, then I'm happy, and I'm sure Alison will be as well, to try to answer as best we can.
Thank you, Michelle. That was a really good summary. I really appreciate it. And before I open it up to questions, the issue of evaluation of social prescribing and the nature of prescribing came up at PNR yesterday, the council, and I think it would be something that would really enhance the decision-making process, if you like, around the way forward. I think these are very valuable supports for people, and it would be good to see it from a general practice perspective as well, in terms of outcomes for people's patients, as well as the qualitative life improvements for the people who undertake those initiatives. I know it's a challenge, but it might be possible to quantify things like reduced medication or changes in that regard. So if that could be considered, I think it would be really helpful for future provision. I've got Elaine Henry first, and then Alison Clement.
Thanks for the report, and I think it's a call to action for what we all. And I think absolutely, I think it's capturing the whole system benefit of that once a month administration of a drug. It's freeing up so many people in so many community pharmacies to do so much other interventions that allow people to maintain self-care at the most community-based level of healthcare, rather than barreling into GP practices to ED. And it's absolutely, it's difficult to show the benefit, but it's definitely there. I suppose the question really is for yourself and for Alison. And my suspicion is, and just having been on the ward this week, is that people have, like a snowball coming downhill, have amalgamated lots and lots of medicines through COVID, and it hasn't been some of that opportune medicine reviews of actually seeing a person in practice and actually weeding out a whole lot of stuff, and that diversion away from those really important medication reviews. And we know that if people are on lots and lots of medicines, they end up in hospital. 30–40% of medical admissions for older people are due to too many medicines. And is there some way that we maybe we need as a board, as a healthcare community, to get back to actually doing that. We can all do them. We just probably need to understand the principles and that it's our job to do them.
Yeah, I mean, I couldn't agree more, Elaine. I think it is really important, and that is something else that we are trying to encourage in Angus, is to really get in and about the polypharmacy reviews, both encouraging the GPs and encouraging the within the practices to proactively look for these patients and see what we can do. I think Alison will probably come in and mention this as well, but we're aware of the learning disabilities polypharmacy work that we want to also get in and about, because again, those patients are going to be around for a long time, and if we can get their medicines right earlier on, then we'll reap the benefits from that from a financial perspective, but the patients will also reap the benefits of that from being on the right medicines. Not to discount that we want to obviously do it for our older population as well, but I think that we've been quite good in the past at doing it with the older population, and we need to widen that out now and really get in and about all of the patients in Angus. Is a very ambitious thing I'm describing here, but get in and about all of the patients in Angus that are carrying that burden of medication, because you're absolutely right. It is one of the biggest things that we could probably do to reduce hospital admissions, would be to get people off a lot of the medicines that they're probably on, that they either no longer require, or we've had additions and now they all don't quite work so well in combination. So I think it's a really, really important point that we do need to not focus too much on the financial aspect and forget that actually there's really good quality clinical reasons for getting in and about what medicines people are on. But I'm sure Alison will probably got more to say about that as well, so I'll be quiet.
Thanks, Michelle. Alison.
Yes, so firstly, your point about nature prescribing, I'm pleased to say that high priority for us as part of the early intervention and proactive care steering group that met on Monday, and our new programme manager for that piece of work, Blair Finlay. So that has been sponsored by the strategic planning group in Angus. It was a risk that we weren't focusing on the early intervention and prevention. So absolutely learning from what happened in Dundee, which is where it has been very successful, and doing something very similar. So an example of where we're learning, in mental health across all. We're delighted Blair's got a public health background, and so we're very much having that sort of support to look at the benefits of our interventions, and we're identifying measures. So with his public health background, he's able to support us with that, because it can be quite tricky to do. We have looked at antidepressant levels in Angus very recently, and they're stable through the pandemic, so we might have expected antidepressant levels to increase, but there's quite a lot of variation between practices, so there's something that we need to think around there. Regarding the polypharmacy issues, absolutely, Elaine, recognise this. I think it's variable between different areas, different prescribers, and we need to get everybody confident and good at polypharmacy. There's been an expectation in the past that that's the responsibility perhaps of the practice pharmacists or paying GPs, but we need to get beyond that to the cultural change around that. And we're doing really well, and we kind of lost a lot of ground during COVID. So disappointing, but it is what it is. We're hoping to have polypharmacy reviews in pharmacist job plans, and it's the tension for a practice pharmacist between supporting the system and just getting people their medicines and sorted out, and the discharge prescriptions and all the rest of it, and actually giving pharmacists what they want to do. Some very highly skilled pharmacists there. So if we can get a balance in their job plans, it would hopefully help with recruitment and retention, which is where we want to be. Regarding the learning disability, that was the plan across Scotland to have people with learning disability. There's not been any funding come through, but we have looked at how we could support having good registers in our practices with the teams. So that's in progress, and we're going to prioritise the things we think are going to be of most benefit in the first instance, and that is around perhaps integrating a long-term condition review with polypharmacy reviews in that population. So it's just to add into the work that Michelle's already described. So not going at a fast enough pace as we would like, but we are making steady progress across a lot of areas, and hopefully that will take off. Certainly maybe difficult over this winter. We're expecting a difficult winter, but certainly into the new year we're planning to really pick up the pace where we can.
Thanks, Alison. I think we know we can do it. You know, it's a case of getting back on track following COVID. Richard Humble.
No, I mean, I agree with Alison and Elaine. I mean, it's obviously, I think COVID's pretty much put everything to pot the last couple of years. I mean, Angus is exactly the same things that that whole document applies to P&K as well. I mean, there aren't enough for the practice pharmacists at the moment. They struggle to even get the MedRec done from the hospital and the medicine requests from clinic. Never get any of the acutes done because there's not enough capacity, not enough time. GPs at the moment, I mean, the last couple of years just don't have enough time when a patient's in to actually do a medication review because they've stored up lots and lots of things from COVID. And they're all taking longer. And demand's up about probably 30-40%, and with less GPs. So realistically, it's going to take a bit of time to get back, and there needs to be some form of you need to have some form of protected time to do it. The other opportunity to do it, which we don't see happen as much unless they've been under MFE in hospital when they're admitted. It doesn't. A lot of the time, certainly during COVID, they were coming out without even the meds being properly reviewed by a pharmacist because they were short of pharmacists. And the practice pharmacists do it. And when they're in hospital, certainly they're under MFE, they tend to get a full pharmacy review. Sometimes you find that sometimes people go in and actually come out more medicines as well, or different medicines. But yeah, I think we've got to work across the whole system, and actually when they're in hospital, get a proper meds rec before they come out, and reduce meds that aren't needed as well. Because obviously it only seems to be when they're under MFE that they do that. So.
Richard, thank you. And even then, it's not guaranteed. Going on the experience I had with my mother. So, David Coulson next. Please.
Thanks, Chair. Lots of mention of pharmacists, so I was compelled to join the conversation as well. And I don't disagree with what Richard and Alison are describing, but I think when we talk about polypharmacy reviews, it's about doing it in the right place for the patient. So some situation is not the right place. If they're going to be in there for a short period of time, it's not the best environment to do that. What Richard describes is that acute frailty team. That's a fantastic model that works across AMU with clinical leadership, both from pharmacy and medicine. Now, that works really, really well. So Michelle and I have been talking about how we can replicate that MFE, acute frailty team model, but deliver it across that whole system as well. I think that's really, really important. There's a significant role here for pharmacists, and Chair, you'll be aware from other forums of the challenge of finding pharmacists as well. We've got some significant. There was a lack of workforce planning around some significant policy changes that took place. That's put us in a really difficult position. So now we have to do that work to attract people back into Tayside and to stand out and do something different. And hopefully this work that I've just alluded to there with Michelle and others, we can start to do that. So I just want to share those points.
Thank you, David. You're absolutely right. I am aware. Okay. Now, Richard, your hand's still up. Is that you want to come in again? No. And Michelle's hand was up and has gone down again. Did you want to come back?
I was going to describe what David's just picked, going to try and do this differently with recruitment and different ways of working. So David's already done.
Super. Thank you. Well, I can bring in Peter Davidson now then. Thanks.
Sorry, Julie, just when you thought you were making progress. Yeah, I found this topic really interesting, being based in the third sector. You know, our local charities exist to provide physiological, emotional, social benefit and work closely with the social prescribers. And my experience of social prescribers are that they're going above and beyond, not just to signpost to third sector organisations, but also trying to develop third sector initiatives to provide that benefit. But I've found information I've heard from Elaine, Alison and Richard really interesting today that 30-40% of older adult admissions are a result of too many medications, that antidepressant levels are stable. I just worry about some of this information not available to the third sector, but the third sector not really being fully aware of some of the stats and the trends. I mean, the antidepressant levels, Alison, you suggested that was based on a type of medications that are being administered, I would envisage at this minute in time. Are these statistics publicly accessible? Because if charities exist to provide that that local need and apply to the likes of the NHS Community Innovation Fund for tests of change to return, you know, for significant returns on investment. I just wonder if these type of figures can be made available so that charities can make more targeted approach to what's happening in their local area.
Okay, I see Alison's hand up. She might want to come in on that.
Right, so antidepressant levels I don't think are currently published on the National Therapeutic Indicator website, although a lot of information around prescribing down to practice level, health and social care partnership level is, and I'm happy to have a conversation with you about that. I don't think there would be a problem around sharing data that we'll have for our own use in Angus. We have a lot of data around prescribing levels around mental health. You would need caution around how you were interpreting some of that. We could happy to support that. I would highlight, though, I think nationally they are looking at whether they can get more indicators around mental health. I'm pretty sure that that's one of the areas that they're working on. And we do have, we're very fortunate to have Andrew Jack, who's a member of the IGB here, who sits on the national group looking at these indicators, and that happened following an engagement event that we had around prescribing. So I know that he's got an interest in that area and could perhaps take that back around how we get that level of information available, sticking with what we've got nationally. It's published on our website, it's updated every 3 months or so.
Andrew, would you like to come in?
Yeah, it's just a lot of that information is available to the public. It's just getting the right links. I mean, it's on the public health website, so I'm sure that could be available. Yeah, it's been a very useful exercise being involved in that. As Alison said, I asked one question too much at an engagement event, so I was invited to join the therapeutic indicator panel developing the respiratory metrics, and that's been quite an eye-opener as well, you know, being a patient and user of respiratory medication. It was quite interesting to see just how much detail goes into measuring the effects of prescribing and the impact, and also how measures are being taken to drive down the inappropriate use of medication across all the sectors. So yeah, I mean, it's been a good experience, and as I said, that information it's very rich and it's available. I'm sure that's certainly to the third sector.
Thanks, Andrew. And that'll teach you to ask too many questions. Eunice's hand is up now.
Thanks, Councillor Bell. Just on the sort of discussion around social prescribing, I thought it would be interesting to let people know that I was at the Angus Council Policy and Resources Committee yesterday looking for an extension of our current arrangement for social prescribing through VAA. And that was supported and agreed, and we're going to then go on to look at a further period of looking at a contract and have that out for tender. But part of the discussions yesterday, people were asking for an evaluation that could be shared with everybody, just so people can see the benefits of social prescribing. So I've agreed to take that forward, and I've made Jill Galloway and Lisa Prudham aware of that. So that will come forth in due course, and we'll be able to share that with IGB members as well. Thank you.
Thanks, Eunice. Appreciate that. And Richard is coming back in.
Yeah, just another comment actually that I thought of in cost and the workload is when I was looking at the mitigating actions about the technical switches and things. The big problem we've had in the last couple of years, you've probably seen it in the press as well, as lots of things being not available. We've all had things where things have been switched. You do a technical switch, then find out it becomes nationally unavailable. So the huge amount of practice pharmacist and technician time and GP time spent writing new prescriptions. Every time there's sometimes a switch to a cheaper thing, there's something else comes along and community pharmacy needs a new script. So there's a huge amount of kind of time spent on that, and that seems to have got worse over the last couple of years. Some to do with Brexit, I think, and supplies, but others to do with manufacturing problems as well. But it's certainly kind of an impact on the costs, but it also the actual workload, the fact that there aren't enough practice pharmacists and sort of technicians and GPs is it we spend our time redoing things that we've done to try and improve efficiency, which is a kind of waste of time. So
yes, I mean, points well made, Richard. Thank you very much. So I'm not seeing any more hands. So can we go back to the recommendations on page 66? And well, we've scrutinised the content of the paper and we've had some rich debate there. Acknowledge the development of the strategic and operational meetings planned for the next financial year and to continue to 24, and request a further update to be provided in June 2023. Is everyone happy with those recommendations? Yeah, okay. Thank you very much, and thanks everyone who contributed to that paper. Appreciate that. And if we can move on now to item 8, which is our winter planning. Gail?
I'll hand straight over to Jill Galloway.
Great. Okay.
Thanks, Gail. Thank you, Chair. So, yeah, this is our annual report in relation to winter planning. And Julie, I think just to reiterate something that you said at the start of the meeting, in relation to thanks to the staff, and I think just going into what is going to be, or we are thinking is going to be, a particularly challenging winter again. We've just had 2 winters where we've had COVID to deal with in addition to other winter pressures. So just to acknowledge and record our thanks on behalf of the partnership in terms of the work and the commitment that all staff put into service all year round, but acknowledging where things are going into winter. So this is the NHS Tayside winter plan that is co-produced with all 4 partners, 3 health and social care partnerships and Acute. The Angus section is on page 111 of the document. I don't know if that's meant to be in terms of our combined document and the NHS 24 number, but that's the number that we start our plan on. So just to draw the board's attention to the actions that have been included in the plan. There's not any big surprises there for people. It's what we tend to do on a day-to-day basis, regardless of whether it's winter or whether it's July. Just to draw your attention though to some of the focused, I guess, funding that we have put into support, and we have listed there the areas that we have invested in to try and support all services across a really challenging time and going into winter. On page 112, just to draw attention to our commitment in relation to the delayed discharge status, and our target is for 3 delayed discharges within 9 wells, an acute setting, and 15 in total, and that includes both mental health and learning disability delays as well. So that's how we assess our RAG position in relation to delayed discharges. Given that we have this every year, Julie, I'm not going to go through it in any more detail, but happy to take questions.
Thank you, Jill, and yeah, absolutely. I'm very mindful that in a lot of areas across public sector services, people are winding down for Christmas and New Year, and the NHS and our care providers keep going. It's relentless, and I really appreciate everyone involved in that. Richard, your hand's up. Is that a legacy hand, or do you want to come in on this paper?
Sorry, it's a legacy hand. Sorry, I didn't realise
Okay,
it didn't
no
automatically go
problem.
down after the last one.
That's okay. In that case, then, can I bring in, first of all, Andrew Jack, and then Catherine Lindsay, and then Sarah Dickey.
Sorry, just a question about the recent incidents of now I never get that name right, but the diphtheria-like illness that's hitting younger people, is that included in the winter plan?
It's not, Andrew, because obviously come to light over the last few days, and obviously the papers have been part of have been out for about a week. No. But in the plan is in relation to infection prevention and control and other respiratory issues and how we work with Health Protection Scotland, for example, should these situations arise. So just based on that, I know that from a primary care perspective, including out of hours, there's been an awful lot of work over the last few days to make sure that we do have access to appropriate treatments for individuals, looking at the pathways, how we can work with paediatrics in particular to support some of the increased demand. And I think there is something around parental concern as well, because obviously the symptoms of Strep A are quite generic. So there is a huge amount of anxiety across the system at the moment. So it isn't specifically named in the plan, Andrew, but we would deal with that in the same way as we would any other kind of increasing incidence of any kind of illness or concern.
Yeah, I do appreciate it's been rather a recent occurrence, but it's good. It's reassuring to know that that's been well worked on. Anyway, yeah, I appreciate the plan came out before this happened. But thanks for the update.
Thanks for the question, Andrew. And I know Public Health Scotland's obviously tracking infections as they happen. Catherine, can I bring you in?
Thank you, Chair. I have two questions. The first one relates to the page 112, where we've talked about increasing capacity in care management and a range of services as one of the ways that we are looking to support the winter plan. And I'm just conscious that later in the agenda there is a financial update that shows a £1.3 million underspend against that area of business. And I just wondered if that was a result of the new monies that are referred to here, and that we've got additional capacity coming in. So that's question number one. And question number two is a more technical question, and it relates to the recommendations, the last recommendation about the direction. And I just noted that the Angus Health and Social Care section of the report is not solely, but is very heavily weighted towards the social work and social care aspects of our delivery. And I just wondered whether or not there was a reason why there's not a similar direction in relation to Angus instruct the Health and Social Care Partnership, in essence, to deliver what is in this plan as part of the wider partnership. Thank you.
Okay, thank you for the questions, and I'm sure Eunice would want to come in relation to the
Hi, are you Colin? Colin, hi, it's nice to meet you. I'm chairing a meeting. You okay?
Yeah, I'm just going to measure from slow to
horse on.
Okay, right. If Eunice is still on, then she'll probably want to come in as well, Catherine, in relation to the care management. But we did put significant investment into care management across all services to support, and as a number of other services and professions, there's significant challenges in recruiting to that. So if Eunice, do you want to come in around that?
Yes, I've not really got anything hugely to add from what you've said, Jill, but yes, I mean, it's a challenge around recruitment, but also I think part of that budget is about the demands on social care, not being able to provide that as well. So we have got issues around managing to meet everybody's needs that are requiring services, and we're doing a lot of activity around that as well. So it really just is around some of the challenges, but because we haven't been able to recruit all the staff we want, we are looking at different ways of prioritising and making sure those that are in most urgent need are getting the services that they require. Thank you.
Thank you. And in relation to the direction, Catherine, I have to be honest, I'm not 100% sure. So we've never done a direction to NHS Tayside on the winter plan before. So this is our first. So I would probably seek both Gail or Sandy or Andrew Thompson's thoughts around that, because it's an NHS Tayside plan. But I appreciate we would be acting on behalf of both parent organisations as well. So happy to take advice on that, and if we need to do a direction to Angus Council, then we could certainly do that.
Can someone come in on that direction?
If I could just come in on the sort of strict legal side of things, there's aspects of the winter plan that are Angus Council's responsibilities. I suppose the direction should be to Angus Council too, but I don't know if anyone else has any comments on that point or has a bit more knowledge of the background.
I suppose they're delegated functions, Andrew, from the council to the IJB, and what we're directing NHS Tayside to do is actually implement their winter plan, because it's an NHS Tayside plan.
Okay.
That was my take on it. So I don't know. We can maybe pick that up offline and then provide an update to the IJB after, if it does come that we need to do a direction to Angus Council as well. But as I say, directions are still relatively new territory for us, so
Yep.
still finding our feet with them.
No, I'm happy to pick that up afterwards.
Great, thank you.
Chair, it's Karen. Sorry to interrupt there. I think in terms of the recommendations, if we're agreeing to the direction, I think that would have to be decided on today rather than coming back to it. If the recommendation, I think it's recommendation 2 is referring to that. So I think if there's any other update that could be given by Andrew, I'm not too sure if he can provide anything else.
Yeah, I suppose I need to dig back into the details of the report. It might take me a few minutes to do that, to come to a sort of clear technical conclusion on the point. But if I'm right in what we're saying is that the plan itself is an NHS plan and the NHS are implementing it, but there's a flow through to Angus in that report. Is that correct?
It is. The title is NHS Tayside and partner organisations, and it's between all 3 health and social care partnerships and Scottish Ambulance Service as well as a partner organisation.
Mm-hmm.
We could maybe take the other questions, Julie, and then come back to Andrew.
Yeah, I was just going to say that this is an interesting situation because, I mean, up until relatively recently, we kind of tried to avoid directions, and then SG explained that they were supposed to be an integral part of just how we do things. So it's less about, hitting a barrier and then having to issue a direction, but just about mainstreaming them. So it's a very good question. So I'll go on to more questions from people and we can hold that thought. Okay, so Sarah Dickey next and then Elaine Henry, please.
Thanks very much. It was just a question around the inclusion or not, I can be guided by colleagues, of care homes within the plan. I couldn't see reference unless I've not been fully cited in terms of our clinical and care to care homes.
In terms of what we're going to do to support care homes during the winter.
Correct. Yes.
In terms of from a wider perspective, I guess, out of hours, we do support care homes and both nursing and residential in terms of fast track to the out of hour service, and that will continue this year given the success that we've had around that. I guess we probably just assume that the care homes is business as usual, so Eunice might want to come in around that as well as to whether we should include anything specific around care homes, but I'm not aware that we will do anything different with care homes.
Thanks, Jill. I think my point is, and apologies if I wasn't clear when I was asking the question, is if this is a whole system plan, the health and social care partnerships are very assured of the arrangement they already have in place with their partners, either out of hours or care homes, because that's your normal business, as you say, whereas NHS Tayside may not be a system plan that needs to be enacted at times of extremis. I was supposedly just thoughtful that the exclusion of care homes doesn't then make it clear to all partners. It was just a thought. Thank you.
We can maybe pick that up, Sarah. So this isn't an extremis plan. This is just the winter plan. This is what we're going to do over winter in general terms. So we do have reference around care home staff and vaccination to support vaccination of care home staff. Eunice, do you want to come in?
Thanks, Jill. I don't really have anything to add. I agree with you. I mean, it is business as usual. You know, we are well engaged with the care homes. We have our weekly CHOG meetings that we can pick things up. We have good connections. Nikki's obviously on the call as well. So nothing else to really add other than it's part of the whole bigger picture. So I do accept what you're saying to a degree, Sarah. Thank you.
Right. I've seen Nikki's hands up, and I think that Nikki's going to come in on that. So do you mind, Elaine, if I leapfrog Nikki in there? Thanks.
Thanks, Councillor Bell. And yeah, just very quickly, just to echo what Eunice was saying, and in addition to the weekly care home operational groups, I have a care home providers forum that still runs every weekly. That's the preference of the care home provider. So anything at all that's raised through that gets fed into, back into the CHOG, so that there's lots and lots of communication and things are picked up at a very early stage, Sarah. So thank you.
Thank you.
Okay, thanks a lot, Nikki. That was helpful. Elaine.
I suppose just to give perhaps one specific bit of assurance, which is about the Strep A disease that we've people. And probably the way that the NHS Tayside and partnership plan, I'll come back to that specific comment in a minute, is that this has actually allowed us to be reactive to emerging threats during the winter. So we have a specific plan for paediatrics, and we planned this on the basis of reacting to COVID in young people, which we didn't see, and then the RSV epidemic we expected post-COVID. And if you look, we've actually made an ability for paediatrics to be able to pivot from outpatient clinics to times great pressure. The clinics move on to telephone at 3 o'clock, and we then open up our assessment bay, expands. We swapped our assessment bay with a clinical admission bay, and we can actually flex out to outpatient, so we can see 4 times the number of young people over the course of a few hours. So it really then brings me back to my main point was that the NHS Tayside and partnership plan, we wrote our first one, is it 4 or 5 years ago now? And I admit an interest that I was the drafter of the first ever whole system plan. And that's what this is. It is very much NHS Tayside and partner. That's our strength as NHS Tayside and partners. We're able to have that whole system working. And that's why on the great majority of days, our emergency department performance is the best of the big hospital boards, because we have that. We're on calls weekly, sometimes daily, with partnership, with many I recognise on the call here, about getting folk out, keeping delayed discharges down, opening up social care packages. That's where any funding we have goes to social care. So I suppose after that 2 demonstrations of what we do, I suppose my question is, my reading of the direction is that NHS Tayside is the holder of the whole system plan, and Angus is saying to delegate it, but it's a live document. It's written at a point in time because we have to get sign off, but it remains a live document, and the spirit and the intent of the plan is to react to whatever the heck the rest of 2022 and the start of 2023 is going to throw at us. It is probably that ask of what is there anything we need to define in the direction, because it is really to enact the plan, and it's almost giving permission to the people who are leading health and social care through the winter to deliver the best they possibly can. That's my reading of it, and it's just to ask with curiosity, is there anything more we need to capture to be able to sign this off? Does that make sense?
I think so, Elaine. Thank you for that. Can anyone answer that? I mean, I was curious to know. I mean, presumably the other IGBs are seeking a similar direction.
So the IGBs, I think, are next week, really, and I have been in touch with the lead officers for both Dundee and Perth, and shared our direction for the plan with them.
Okay, Gail.
No, both the other chief officers felt that we are partners in the winter plan. We're all equal partners, so they had no intention of raising a direction.
Okay, so what I'm going to suggest now is that perhaps we need some legal confirmation on that. And would Andrew Thompson be able to help there? I was going to suggest a short adjournment to allow that to happen, but Sandy's coming in.
Yeah, Julie, if you don't mind, sorry, Chair, if you don't mind.
Not at all.
I think you kind of alluded earlier on to the fact that we hadn't used directions so much in previous years and we were following Scottish Government advice. I just kind of almost reflect on what Elaine was saying just a second ago. You know, are we just looking for permission to do all that we need to do during the coming winter? And essentially that's what we are. I think if we try to be over prescriptive, it doesn't work in a direction, because what we have to do, of course, evolves and changes. I think I would be probably inclined to leave the direction as it is, with the paper as it is, because we know things will change as we respond to things. But the simple change we could probably make is just say that is the Angus Council on the HST side, because we know in Angus we're working across both. And honestly, from my perspective, I don't think we need to do much more than that. If we try to be more prescriptive in it, it doesn't work. You know, to try and pick it apart, it's almost too brittle a mechanism to try and overanalyze it. So I would be tempted to keep it broad as it is right now, but include Angus Council, and then we have all the permissions in place to move on.
Okay, I find that an acceptable approach. Would everyone agree with that? And that will allow us to move on. Yes.
Sandy, sorry, just one thing, just to clarify, to include Angus Council, just mean exactly what you mean by that.
Well, the direction is currently written to NHST side, but
Yeah.
you flagged up, and we can see it in here. There are one or two things that we'll be doing that reference things like care management and home care. Now, they've possibly been picked up previously. This is not brand new stuff. This is a report of things that we have sometimes done in the past. But I think if we try to be over prescriptive, it kind of won't work. But if we're really saying to the whole system, which is, we need whole system support to help us deliver the various components of this, I think that would probably work for us. But to try and be too specific will be too hard to do. But we've got things that we are working with Angus Council on, referred to in this report. I think therefore, kind of in its widest sense, we could probably say this direction is to both partners. Yeah.
Okay.
You happy with that, Andrew?
Yeah, that's fine.
In terms of equity of partnership, it makes sense to me. If we're going to issue direction to one, we need to do it to the other. And it's really just consolidating in process and the audit trail that we've joined those dots. So if I can go back to the recommendations on page 71, I would ask that we can approve all of these recommendations with the edit to recommendation 5, that we issue a direction to NHS Tayside and Angus Council. Is everyone in agreement with that? Yep. Okay, I'm going to suggest, we're just coming up to 4 o'clock, we have a 5-minute comfort break, taking us to 4:05. And apologies for me having to duck out briefly earlier. Somebody unexpected came to my door, the dog got out and hens invaded the kitchen. So apologies for that. See you at 4:05. Thanks. you for that. Could I just ask if we're recording again? Thanks, Sandra. Okay,
Chair,
so
can I just double check? Sorry, it's Karen. Can I just double check that our voting members that we are Corey? I'm just making sure that everybody's on camera. Hold on a second.
don't nobody move.
I know. I am just checking. Is Councillor Speed there?
I can see her down
Here.
as the
Right,
participant.
okay.
Yeah, yeah.
That's fine. Chair, good to go. Thanks, Sandra. We can start recording. Thanks.
Thanks, Karen. Okay, so welcome back, and can we go straight into agenda item number 9, please, which is the NHS Tayside and Social Care digital update. And I understand we have Angela Murphy to talk to us on this one this afternoon.
Can I introduce
you
the
may.
start of this? Unfortunately, neither Lake Kalik or any other member of his digital directorate are able to attend our IGB this afternoon. So what we'll do is, first of all, we'll go over the information that is in the report, because the purpose of the report was to update the IGB on the work that's been progressed by the digital directorate in delivering the digital strategy. So they've included a lot of information that I don't propose to go over. The keypad, I think, is the COSLA one, Peter, that they've used there. And they've highlighted that based on the 5 key themes that you'll probably all recall are in the digital strategy, and they've actually looked at where they are with these programmes of work. What we really need to be focused on now is where are Angus? What are we doing in Angus? And Angela Murphy, as you know, agreed to be a joint chair with regard to setting up a new Angus Digital Partnership Group. And Angela went off and started that, I think, about August or September time. So we'd like to bring Angela in here now to update you on the work that we're doing locally in Angus. And I hope Angela's there.
I am, Gail, thank you.
Oh, thank you, Angela. I can't see you.
Yes, as Gail mentioned, the majority of this paper has been written by the Digital Directorate. However, if you do have any questions from that part of it, I will do my best either to answer or certainly find an answer for you and get back to you. But what I hope you find helpful is I asterisked a few of the items that the Digital Directorate had given you an update on, and put the Angus slant on that, and hopefully turned it into relatively plain English that most of us will understand. There's still elements that confuse me, certainly within the main part of the paper. But as I say, if there are any questions, I would certainly do my best. But taking you to the appendix, which is looking at that Angus position, and the first item is very much around the replacement electronic patient record, which will be for almost all of our community services in the partnership, and also includes a lot of child health services, so health visiting as well are part of the electronic patient record. So we're currently on a system which is due to finish early next year. The contract will end, and a new system has been found which looks very promising and looks like it will address a lot of the issues we have had with the current system. So we'll very much look forward to that, but it is still going through the procurement stages that all have to be done, and the full business case is to be presented to NHS Tayside for the purchase of this. But the main advantage will be is it will allow all of our community staff to actually carry the patient record with them on a mobile device, which is we're still to decide on which will be the best mobile device for that. But it means that as you're in a patient's house, that you'll be able to access their NHS and GP record, and you'll be able to write the electronic patient record while you're with the patient. And basically it removes that need that there is just now of having to return to base all of the time to go into a desktop computer in order to access the record. It's not perfect by any means, and still is limited in the fact that you do still need to be able to get an internet connection. However, the new system does allow you to download all your patients at the beginning of the day so that you can access a record, you can update the record, but then it has to be synced at some point when you get back into an internet connection. But that will save so much time, particularly for our community nurses and our community AHPs. Most of our community AHPs are still on a paper record, but we will be going on to the current system just so that we are able to move on to the new system along with everybody else. Otherwise, we would have quite a wait. But it's a system that is designed for community, which is fantastic. So you may have some questions about that, but I'll just move on to the next item, which is a very short one, and it's just about Microsoft 365, and we will have the opportunity of that being integrated between health and social care. So, for instance, we will have some guests at this meeting, but everybody's information will be there. We will all have the same rights within a Microsoft Teams meeting. Will make a lot difference to the actual day-to-day work for all of us who are using Teams all of the time. It prevents the need for having two logins, so you don't need a council login and an NHS login. So that's something to look forward to, and we expect that to happen relatively soon. It's been trialled elsewhere and does work. A brief mention of the GP IT system. It's been renewed, and that's been tested in 2 Angus practices and has been working well, and there's now a rollout programme, which I think will probably take a wee bit over a year to get out to all of the practices, but it will mean that all NHS Tayside practices will actually be on the one system. At the moment, there's I think 3 practices use a different system. So again, that's another very positive move that's happening. The next part about track care, it's mentioned again in the update, and there's not a lot of information about this just now, but they are looking within the acute sector, or maybe more accurately the inpatient sector in NHS Tayside, to be using track care as their electronic patient record. Now, it's really disappointing that they're not moving on to the same system as the community, but the community system does not cover inpatients, and the inpatient system is really no good at all for community. So it's just a wee bit early for us to be on the one system, but we have heard that there's good connections between the new community system and track care. So that again is a positive moving forward, but it does mean we don't have a easy flow of information coming in and out. It does mean having to access other systems. And then finally, as Gail mentioned there, we have set up an Angus digital group. We've had 2 meetings so far. We've got excellent representation from all of the partnership services, and we have got IT from Angus Council and the Digital Directorate from NHS Tayside are attending, and we can see right away how beneficial this is going to be to the communication and involvement of all services in what's happening digitally, and also, you know, the sharing of innovation that is happening already within all our services. We want to make sure that everybody is aware of what's happening and how that can help in other services as well. So I also run a digital group for AHPs in Tayside, and I have to say that both of these groups are a total pleasure to chair and be involved in, because the people around the table are really, really motivated and excited about digital working. So, and it's we get clinicians wherever possible involved in it, and managers that have got an interest as well. So I think it will really be a very helpful group in moving us forward better within Angus as well as Tayside. So happy to take any questions that you have, and as I say, if I don't know the answer, I will find somebody that does.
Angela, thank you very much, and it's a great comfort to know that there's that clinical involvement in those groups. It's absolutely critical when introduced. I have an initial question before I open it up, and it's when Lake first presented this strategy to us, that it was clear that there was no financial framework around it, and this paper says that implications in this paper, yet there are clearly financial repercussions of implementing this information will sit going forward. I don't, somebody will be signing off those commitments. So I wonder if someone could give me any assurance that that is being dealt with somewhere.
Yeah, hopefully that this is a sufficient enough answer for you. The update itself, I suppose, doesn't identify any specific financial part to it. But certainly, as I've just been describing, particularly around the new electronic patient record for community, it will have a financial impact on us, particularly with the purchase of mobile IT. However, that has been accounted for. Hopefully Sandy can confirm exactly where that's coming from, but we have got an amount of money earmarked for the purchase of the mobile equipment for the staff. So I've not great concerns about that. The actual implementation of it will involve a lot of staff time and staff training, etc. And at the moment, as they're completing the full business case for the new system, that they're looking to include that kind of information in it, and they're in contact with services to make sure that that is included.
Okay, thanks, Angela. I'll maybe leave, if Sandy's got anything on that, we can leave it until later on, because there's quite a few hands have popped up and I don't want to hog it. So first of all, Andrew Jack and then Richard Humble, please.
Hi, Julian. Thanks for, sorry, Angela, thanks for, it's getting late in the day. Thanks for going to all the trouble to distill out the Angus specific stuff and write it in plain English. I was particularly drawn to the electronic records, the electronic patient records, and I can appreciate how much it will make the work of the mobile community health force much easier. They've enough to do without all that admin block on top of it. My question is that, do you know, it's probably an obvious question, is this these electronic records going to sort of start from a certain point, or have all the legacy records been uploaded into electronic form? Because I know the last time I was at an inpatient setting, I think they had to employ a weightlifter to lift my records up. It's a huge looking file, and that wasn't that long ago. So just that reassurance that you can get all the way back.
Yes, there are rules and regulations that we follow with our patient records. So some records can be destroyed after a certain period of time, and the majority are there for your lifetime and for a period after that as well. So yes, they do put in arrangements to digitalise past records so that they are accessible. Some records, I'll comment on physiotherapy records just because I've got intimate knowledge of that. We keep them for, it's either 6 or 7 years, the paper record from the last contact that we have, and then they are destroyed. So we will keep the paper records that are already in existence, and they will go through that natural lifetime process and be destroyed at the right time. And from a certain point onwards, the records will become electronic. And where an electronic system is already being used, as in the current system, there is a method of transferring all of that information over from the old system into the new system, and that is part of all the costing that they do in their business case.
Thank you for that.
Thank you. And Richard?
Yeah, just a couple of points. I mean, yeah, it's great the access to that staff will have access to the information on the go and actually mobile devices because you need it. I mean, we have limited stuff in general practice at the moment. We can access the main clinical system, but not all the documents and everything, unless you carry a laptop around that's got you can get it with a VPN token, the handheld devices. So it'd be good to see progress. Hopefully with some we don't want them all to integrate. I think if you integrated out all the records completely, we get a lot of rubbish and stuff that other people don't need to know. You'd spend your entire day looking through bits of data that's not relevant to you and obviously try to find the bits you need. But hopefully some of the data can eventually link into the GP systems. It depends on what system you're using, because things like the community nurses going out and doing like diabetic foot checks, blood pressures, this sort of thing, at the moment they tend not to enter them on our Vision system, on the Vision Anywhere system. They tend to use their own system, so you're not really sharing the data much, and obviously then you have to go looking for or double entering it. Yeah, Microsoft 365 makes perfect sense for everyone, like, to be shared, because at the moment it means you're all going to be access the right templates. We've had for years before we got the new Windows, where basically people were sending documents around that weren't compatible with anyone else's anyone else's versions of it. Just one note on ITV provisioning. I understand that the last Angus practice that went over has had problems with its rollout. I've got a vested interest because we were actually next to go, but evidently it's really slowed down. It was going well, but it's slowed down. So it's behind just because of general things. But there is only actually one provider now nationally. So basically the others have all pulled out. So Tayside actually has an advantage in the fact that we actually have gone for we actually opted for the system and got a direct award that actually we've wanted to go for. So our supplier is the one that's left. So that gives us an advantage.
That's a relief.
Yeah, it's a good job we worked with the other one, because I think the Glasgow GPs were getting quite anxious about it because they haven't done a transfer across to another system for a while. Just one point about the track care encounter record. Will that be visible, obviously, on things like the portal and things? Because I know at the moment they seem to be using a thing called Decora for inpatient records.
That's correct.
And for some of the community hospitals, and it seems to work very well because what we found is the pharmacist and the GP, if you want to find out something missing from the discharge letter, you can actually look on the inpatient record and actually find out what happened, because rather than phoning backwards and forwards, trying to phone wards. So if it's going to be visible on the portal, that is good. So you don't need to integrate it or be dumped to us obviously by a DocMan, but it's handy to have access to the electronic record from the admission to the ward to find out what's happening.
Absolutely, it'll make a really big difference to a lot of services. I would hope that it will be accessible via the portal. I do know that the new community system, when we can publish documents, and that is going into the clinical portal. So again, that will be an additional sharing of information, which will be positive. Yeah.
Okay, good, thanks.
Thank you both. And Donald, then Sarah, then Catherine.
Thank you, Chair, and thank you, Angela. I mean, I thought really useful as a user's guide or an idiot's guide to what's happening in IT. But when I looked through it, the thing that I didn't see was any reference to Near Me. You know, the patient access to GPs, the remote access. And I was just curious why that was. I mean, is that now taken as business as usual and in the bag, or is anything more being done to roll it out?
Yes, it is rolled out across GP practice and across community teams. Acute services use it as well. It's probably not used as much as we would like, and there is further work going on, not as a development, because it has been developed and it has been rolled out, and services have the equipment, but there is still work undergoing in a lot of the services to try and increase the usage of it again. We did find there was a little bit of a kickback from the public, who were very happy to use Near Me during COVID, but COVID is over and they want to see people in person again. However, it very much still has a place in what we can offer patients. So we've tried to change the emphasis on ensuring that when we offer a patient an appointment, that they get the option of near me or telephone or face-to-face. For some patients, it's fantastic, to be able to use either near me or telephone. And there are lots of consultations that's absolutely sufficient and fine. And when it's not, we do invite people to come in face-to-face if we have got any concerns. But we do still use near me, and we do still use telephone consultations a lot in GP practices. I'm sure Alison would confirm, and also in our AHP services, which I've got a lot of knowledge of, and it allows us to be very flexible in how we deliver our service. For instance, the first contact physio service, the majority are still phone call, but it means that we can speak to any patient in Angus. You don't have to live in Arbroath to speak to and wait for an Arbroath physio to speak to. You can speak to any of the physios within the system. But as I say, we always do follow up with face-to-face if that is required from the consultation.
Thank you.
Thanks, Angela. Sarah?
Thank you. Thanks, Angela, for the Angus position. Just in relation to the assessment for devices that will help support community nursing teams, obviously of particular interest to myself, I am concerned around the pace at which this is being delivered and implemented. If I think about the strategic direction for Angus and caring for more people within a home or homely environment as part of the vision of what we're trying to achieve, this digital strategy is absolutely not keeping pace with what our teams need to do, where they need to be, the documentation that they're required to do from a professional regulatory bit. So I hear and welcome the transparency of this report, but I am absolutely not content with the pace of the spread and implementation across our communities for these mobile devices. I feel that it's not being given adequate priority in line with all of the other things that are happening. I feel it's too far down the pile, and patient safety becomes a concern in these circumstances. It's not really a question, Angela, it was more my comment for other board members to note my concern. Thank you.
Thank you, Sarah. And I think the logical question thereafter is, how can we reflect that concern in scaling up the pace? And I'm not sure Angela could maybe answer that just now, but that's maybe something to take away to the group. I can
certainly, sorry to interrupt, but I can certainly give an assurance from the Angus point of view, is that we have identified funding for the devices, and we are awaiting the recommendation as to which device we move forward with. There is a bit of debate with one device looking rather swish, and you can do this, that and the other with it, and another device that is a laptop, and which is better, and perhaps the most reliable one is the laptop, but staff are quite keen on getting the swish one, so it's a matter of making a decision on that. But separately we have the identified funding, which puts us ahead of the game to a certain extent, and I would certainly expect, and we have already prior to now purchased a lot of mobile devices for our community teams. So we're not starting from a place of zero, we're starting from maybe a third of teams already having some kind of mobile device. But I would fully expect that our community teams will have a mobile device before the new electronic patient record, which is the one that will work most successfully with a mobile device, whereas the current system doesn't work terribly well with it. So I've maybe got a wee bit less concern about that, Sarah, than what you've expressed, but that is an Angus position, and I'm not sure what the position is across the other services.
Thanks, Angela. Just for clarification, my contact finance, it's about the unintended consequences on patient safety because of the lack of pace of the timescales associated with this programme, not the financial part. Thank you.
Thank you. Catherine?
Oh, Chair, I wasn't sure whether Gail perhaps had wanted to come in on the last point, or if you're happy for me to go ahead.
Yes, my point is on the last point, Catherine. Thank you.
Okay.
Sarah, like you, I'm also concerned at the pace. Way back in 2015, as part of a piece of work I was doing through the master's programme, we tested 2 pieces of mobile device, and it's a bit frustrating. Here we are 7 years down the line. So likewise, Angela, I wondered if we could put a timescale on this, and if we could even test both devices somewhere in Angus, or we could offer to do that now, you know, because I'm not saying the all singing, all dancing one is any better, but from my understanding and the challenges way back in 2015, it was around connectivity. It was the biggest issue, and one of the areas we tested it was in Edsel, and the staff had to come back to base. It was defeating the purpose, because when they were out the back of Beyond, it didn't work. So I'm looking for assurance that somebody has looked at connectivity and that issue is also being addressed, Angela.
Well, absolutely, Gail, and that's why we really can't progress with mobile technology until we go into the new system. And there's a lot of work to be done before we go onto that new system. I would envisage the end of next year, and before that happens, we will have mobile technology up and running, but we won't be able to use it properly because we're still using the old electronic patient record, which requires you to be connected to the internet no matter where you are. So it still won't work 7 years later, Gail. But I am very assured that the new system does work and allow you to download the patient information before you go out.
I'm just wondering here, is there anything we need to do that could support speeding this up? A direction, a commitment to look at a pilot, the way Gail suggested? What do you think, Gail or Angela?
It's been piloted, the 2 devices are being piloted in Perth and Kinross at the moment. And without, you know, saying what devices we were looking at, but they are piloting the flashy one, let me put it like that, and they are saying that it's working very, very well. However, we have information from our Angus Council IT colleagues that it didn't work terribly well. The same device didn't work well with the council. So that's put a wee note of caution in our way forward. So it's a bit of a balancing act, Julie, but it is being piloted in Perth and Kinross, and that was the agreement from all community nurses in Tayside that it would be piloted there.
Right. So Gail's wanting to come in.
And like what you're saying though, Angela, and the IT challenges, I think we maybe need to go back and rethink that and actually see if we should pilot, at least test that in Angus in a few areas. And like Sarah, I wouldn't want to be held up and then suddenly find something that didn't work, because these conversations have been taking place over the many years. And like you, Sarah, a sense of frustration there for our nursing colleagues, and really around health and safety. And security of records, etc. When it's in paper format is a big risk for us.
I certainly think that the thing that's holding us back is the new system, which we've got an awful lot of work to put into that new system working for us here in Angus and in Tayside, and that can only happen at a certain pace. So that's what's holding us back, not really anything else now.
Okay, if there's anything that this IGB could do to improve that, to help you, have a think about that while I ask Catherine to come in with her question.
Thank you, Chair. I don't want to unnecessarily prolong the discussion, but I had originally, when I read this paper, struggled to understand, and I think I raised it when the original strategy was brought to us, how it relates to social care. And, you know, I'm pleased, in fact, I'm delighted to hear the update in relation to the rollout of 365 through Scottish Government. And I think everybody on this call will absolutely appreciate how much more simple it will make to get in touch with colleagues that you work with all the time, arrange meetings, etc. And that actually, Cascades, is not just from a strategic level where we're all operating at, but also in terms of the practicalities of organising very fast time meetings to keep people safe. So IRDs and, you know, protecting people case conferences. So it's actually a huge contribution and a big step forward. I think it will make a real difference to people on the ground. But I suppose the bit that I would have liked to have seen in the strategy and the update is something that ties the activity to some of the bigger actions and recommendations arising from the P19 SCR and from other SCRs across the country about information sharing and single records across both social work and social care records and into health and arguably other partners. And I don't see that anywhere. And I'm just kind of wondering whether or not, Angela, you've got any sense of where that might be located as an activity or action.
Angela, do you want to come in?
If I got it muted myself, sorry. My understanding is that the majority of that work is happening higher with Scottish Government and perhaps moving forward into the National Care Service. And that's one of the reasons that specifically it was called a health and social care strategy, as was the Scottish Government one. So it was almost trying to replicate that down to our level. They are also looking wherever possible at where we can link the systems in Tayside, and particularly within councils and the health systems. So it's not being ignored, but there isn't a lot of progress on that as yet. From that higher Scottish Government side of things, they are looking at that single digital platform that will allow the sharing of certain information. And I think the first one that they are looking for, and the name of it escapes me, is that anticipatory care plan, and it's got a specific name which they've been doing on paper, but will probably be the first one digitally that will be accessible to all the different partners. So not a lot happening locally, Catherine, I would say, but probably much more at that higher level. Okay, it doesn't stop us raising it at every opportunity.
Absolutely. Can I suggest that we go back and look at that recommendation on page 124 and suggest that we request another update at an appropriate timescale, given the concerns that have been raised in this discussion? And I'll take guidance from you, Angela, in terms of timing for that. But I think just leaving it hanging doesn't give anyone assurance of progress, particularly in relation to Sarah's comments. So what do you think? I think obviously February is too soon. What are the options following that, Karen? Because I haven't got my diary to hand.
April, Chair, and June.
Okay, yeah. Angela, what do you think is doable from the group's perspective?
Probably June is maybe the most realistic.
Okay. Is everyone happy to go with that? And that gives Angela time to raise those issues with the group and to come back with progress on the concerns, and potentially offline to discuss an Angus pilot along the lines that Gail suggested. So happy to accept the recommendation there. I guess we have some limited assurance there, but hopefully that will be addressed by another update in June on the agenda. Everyone happy with that? Yeah, excellent. Thank you very much. And thank you, Angela. I appreciate you were at the very pointy end there, and you did really well. So I appreciate you coming along. Thanks very much.
Thank you.
Okay. And if we can move on now to the finance report, and Sandy.
Yeah, thanks, Chair. Hi, everybody. I'll go through this relatively quickly, but what I'll do is I'll pick up some important points, but also some examples of points. They're often issues that kind of repeat themselves throughout our reports. Firstly, at this time of year, in an ideal world, we would have shared a deeper update regarding strategic financial planning. You'll see at Appendix 5, which I'll come on to in a couple of minutes, we've only got a single page or update or so rather than a separate paper. So apologies for that. In terms of the core report, on page 130 of the notes, in section 2 in the background section, we do note that we are underspending. We knew that anyway. All the reports for this year have said the same thing. But we've also noted that we have already agreed at a previous meeting that we would use some of that underspend to support the wider system. That's what that's what we will be working on that basis going forward. Just using a couple of examples in section 3.1. Using that as an example because it's first in the report, there's examples of underspends being triggered by vacancies and recruitment challenges. That is a feature throughout the report, and you'll see that elsewhere. Conversely, in section 3.2, we do highlight that we do still have some areas of overspend, and these are often areas, or some of the areas that have overspends in them are areas that have seen changes to do with COVID, and the out of hours service is one area that's overspending. And we are looking to develop a finance recovery plan for that. And I mention that partly as an example because it does then feature in our recommendations. Coming on further through the report at section 3.13 on page 134, we give our regular update about where we are with some of our savings plans. The table set out, table 2 in section 3.13, kind of shows things that we've discussed in previous meetings and things that we will discuss in future meetings. There's a few things now lined up for February. That obviously shows only limited progress against a 3-year target, not a 1-year target. The second column of this is a 3-year target, but that's an important kind of benchmark of where we are with some things that we've said we would get done. The paragraphs below that particularly refer to what we call the executive management team savings. That is an area that we have got quite a bit of work to still do, but is one that hopefully we will be able to get that done relatively soon, and we're hoping to get that wrapped up by January. Further on in the report, page 136, I'm skipping past some of the detail about risks, but in the risk section, on page 136 at section 5.3, we've just got a kind of small paragraph in there, but I think it's something that most people would recognise. There is an increased risk regarding government funding of all parts of the public sector in the years to come. We will obviously be part of that. Our funding comes through NHS Tayside and Angus Council. They'll all be affected by that. So we aren't sure how this is going to play out. There'll be a Scottish budget later on this month, next week, I think. And that will start to give us some clarity on this, but it is an area of increased concern for us compared perhaps with where we were 6 or 8 months ago. Picking up on that theme and skipping past some of the appendices which have got regular information, such as the finance position, if I go to page 141, which is the final page of the finance report, this is where we do have a 1-page strategic financial planning update. As I said, in an ideal world where things that are quite uncertain were a bit more certain, we'd have probably had a more complete report, but we are dealing with lots of uncertainties right now. Scottish Government funding being one of those. We've also still got the leftover capacity issues that we're still working our way through within the IGB. So there's a few things that complicate bringing the plans together. But I put together a series of bullet points here that just describe where we are. There's a section across the middle, updates regarding 23 and 24. And And towards the end of that, I said, previously we might have had a £6 million shortfall, but by 24-25, I can't help but think that that is going to be a wider shortfall when we look at the likely government funding coming through. And of course, then we look into the year beyond 24-25 into 25-26, and it'll widen further. And that's one of the main kind of risks for us, I suppose, is that government funding doesn't keep pace with the inflationary pressures that we're trying to manage. And we've moved out of a low inflation environment into one that's much more challenging, as we all know. And so that is a new risk, and probably quite a significant risk for us. But I honestly do not know how that's going to pan out, but we will be clearer in a week or so. And then just to kind of wrap that page up, the very final section of that page on page 141 is important for us, because this is one of those years where we link our strategic financial planning very directly with the development of a new strategic commissioning plan. We only develop new strategic commissioning plans every 3 or 4 years. The two are very much meant to be synchronized and meant to be very consistent with each other. And really, we need to make sure that our strategic commissioning plan is deliverable on a sustainable basis over its duration. And from a finance perspective, or the money resource perspective, that would imply that we are able to develop a balanced or near balanced strategic financial plan. And at the moment, we are some way away from that. So that is an area that we obviously need to be focusing on and closing out over the coming weeks and months. And that's partly reflective of some of the tables I mentioned earlier on. Chair, that's me just kind of picked up, as say, some salient points, but also some examples of things that repeat themselves through the paper.
Thank you, Sandy. Always appreciate your plain English summary of all of that. Does anyone have any questions for Sandy? Well, Elaine?
Thanks, Sandy. It's a really helpful plan. I suppose it's just interested about the IJB reserves and the large hospital set aside and that financial instruments that sit between the IJBs and NHS Tayside board. And I suppose it's really, I get a sense in the support, there's a lot of about what we're going to get and what we're going to have to use and how we're going to have to try and balance the needs versus what we have. Do you know when you'll have clarity? Do you think there's more information coming from Scottish Government before the end of the financial year? Or I suppose it's really just to understand, I'm just very aware as well, within acute, we are very conscious of the pressures to the end of this financial year and next financial year. And do you think we will have, when will we have to make decisions and when will we get clarity?
Well, Elaine, that's an awful complicated question in terms of asking it, but it's quite a hard one to respond to as well, because there's a few different things mixed up in there. I think locally we have made commitment, as you know, at the last IJB to try and help the wider systems as best we can from some of the reserves that we have. So that's a commitment we've already made, and we'll follow through on that, just making sure we have the right bits and pieces in the right places at the right time. I put in section 3.7 of this report just a kind of a reference to some information that was included in, it's on page 132, some information that was included in NHS Tayside's October finance reports it was. And it was just talking about the link between capacity in Nine Wells, which is possibly one of the things you're referring to, and the way that the populations from individual parts of Tayside are using that Nine Wells resource. So that's something that we'll follow up. I've actually got a meeting with some NHS Tayside finance reps next week about this area. So hopefully we'll be able to be a bit clearer about that in the near future. Our use of acute beds has gone up in the last wee while, but it's still quite a bit below where we were in 2016, 17 and 18. So I think it's dipped and now it's come back up. So we'll look at that. And obviously we monitor our delayed discharges all the time and try and keep those down as best we can. So we've got a couple of things we're doing. As I say, we've got the overall commitment to support the wider systems. That's already been agreed. And I've got some meetings with finance contacts in Nine Wells and NHS Tayside next week, and I'll be sharing the output of that initially through management groups, and then it might, if it needed to, it might come back to this group as well. Hopefully that's okay, Elaine, in terms of answering that. I don't think there's much we're going to hear from the Scottish Government, as far as I'm aware, that will help answer any of those questions, certainly with respect to this financial year.
That's really helpful, thank you.
Okay.
Just on the back of that, Sandy, I know we made a commitment to provide some resources to ease pressures across the system. Have other partners done similar?
Chair, I've not really been following what other partners have done on that particular front, Chair. I mean, I think we had to respond to where we were in terms of our financial position, and the also reflecting decisions we made in previous financial years, where we've made various judgments about how we would utilise funding to support various parts of the system. So I've not really been tracking what other people are doing. I think we knew that our financial position was quite strong going into COVID, in terms of we were quite balanced. What we've seen, though, is we've come through COVID, we've now come into a period where we've actually struggled to recruit, and we do have levels of unmet care and things like that. And those, unfortunately, are generating underspends in our system, not planned underspends, but underspends in our system right now on one or two bases. And there's some of the resources that we're helping, anticipating we'd be able to support the wider system. So we have referenced that in the financial reports, that some of the vacancies that are hopefully short term or will remodel our staffing requirements, we'll eventually be able to get that funding deployed into the system to deliver all the things we need to. But for now, on a time limited basis, that is generating some of the underspends, and that is something that's pertinent to our financial position rather than other people's positions.
Okay, thanks very much, Sandy. Anyone else? I'm not seeing any more hands. So with that in mind, can we then move to accept all the recommendations as listed on page 130? Everyone happy to do that? Thank you very much, Sandy. That's brilliant. And moving on to the last paper, which is the Clinical Care and Professional Governance Mid-Year Report. Who's going to take us into that?
Dr. Alison Clement, Chair.
Marvellous, thank you. Alison.
Thank you, Chair. So this is the we've provided annual assurance reports, but following an audit, it was agreed that we would be providing mid-year report rather than leaving it to the year and then in case there's any issues. The group is working well, it's got good engagement, wide stakeholder involvement in the meetings, in good attendance. They are meeting and they alternate between an assurance meeting one month and a risk meeting the next month. And we're reporting, as well as reporting here to the IJB, we also report to the Tayside Care Governance Committee, where we have received, we've offered and been accepted reasonable assurance. Highlights would be that we're building a strong clinical governance team in Angus. We now have a coordinator and a facilitator, and that is allowing us to provide increasing support to the service level clinical care and professional governance groups, and that is working well. Our service assurance reports are making improvements, so we can see with time most of the services are improving in their outcomes and whether or not we're able to identify. There's a wide range of topics discussed. We've got our Infection Prevention and Control Committee, which has been led by Karen Fletcher, our lead nurse, and that is going well. We've got public reps attending that, and we are making good progress. So I'm not going to talk, it's the last report, I don't want to talk for too long, but you can see the range of schedule of business there, and I'm happy to receive any questions you might have.
That's fantastic, thank you. This report used to come to Audit Committee and we felt it was value to the whole board, just to see the broad range of areas that you're looking at. So I appreciate the work done on these topics. Catherine, thanks.
Thank you. Just wanted to come in to say it's an extremely helpful report to have the oversight, and I appreciate it coming to this meeting as well, and for all the work that Alison and colleagues do in coordinating and overseeing this activity on our behalf. I just wanted to pick up one small point of accuracy in Appendix 1, which is just to clarify, I think it's a hangover from previous years, but the Chief Social Worker is not a member of the CCPG and is represented by the head of service with a social work background instead. Thank you.
Thank you. That is just a hangover, that change. Thank you.
Okay, thank you very much. And thanks again. I'm not seeing any more hands. So, oh, Elaine Henry's popped in there. Just made it, Elaine.
Thank you. You know, it's really helpful to have the report, and I suppose it probably is to seek assurance if there were any significant areas of exception or areas of stress or concern from the committee, just to understand the kind of escalation framework, and I suppose it's recognising the huge depth and breadth that you've been looking at things, but I suppose it's just my immediate response is to think, well, is everything absolutely fine, or are there areas here that are of concern and require action and improvement? So I suppose it's just how the summation of this report, how anything that needs to be escalated, how that would come to us at our regular meetings, but is there anything from this report that you think needs to be escalated?
No, there's nothing at the moment, Elaine, and we do provide reports every second month to the Angus Executive Team. We have the heads of service at CCPG, so there, and Sarah is there as well, and representing the Chief Social Worker. So when we're carrying out the work of clinical care and professional governance, we are able to escalate any issues to EMT, and we would be escalating. The issues that we've escalated within NHS Tayside are largely around the sustainability of primary care risk and our risks. That's what they ask us to do. And there's an extensive schedule of work ongoing led by Gail, and I don't think David's still on, but David Shaw, around the output from the sustainability of primary care audit. And a lot of the issues there raised and escalated are around the engagement around premises and being able to deliver our future strategy for primary care and how we work across the three partnerships and with NHS Tayside. So that's coming forward through that work through the Primary Care Board, and looking at whether there would be devolved responsibility from all four partners to support that in the future. The other key risks, and they are subject to other reports to the IJB, so I've not focused much on the risks, but they are around workforce, commission service provider failure, and early intervention and prevention strategic risks. So these risks are all being escalated in the appropriate way also. And regarding assurance from individual services, the heads of service are there so they're able to take action as appropriate. But there's nothing particular I would wish to escalate to the IJB today.
Thank you, Alison. And as a member of the Care Governance Committee, I endorse what you've said there. Elaine, come back in.
Yeah, no, I suppose just reflecting that there's many assurance reports I give and receive, but often the bit that we're drawn to is that those red risks that we hold and carry, and it's almost that visibility. And absolutely, I think you're right. The sustainability of primary care, and we have the primary care premises that there are, and service, that risk of service failure, which is often dynamic risks, and it's just that visibility sometimes, and that drawing it to the front of people's minds of where our highest risks sit, because they're held by the IJB officers, by the people delivering them, and it's just whether there's collating those, as you've done today, verbally, whether that might be an option for a future report. It's just a thought.
Yeah, I think the risk table was in and then it was out. So it's just I wouldn't want to replicate the work that is done through the strategic risk report, which also comes 6 monthly. So that was the reason for not including it, but I'm happy to make sure we're aligning these and referring, so that made clear.
Okay, thank you. Gail?
Yes, I was about to say the same. We already have that, Elaine, in the risk report that comes. And also remember that myself and Jill Galloway deputises when I can't attend the Tayside Risk Committee, and I also attend the Care Governance Committee when required, and I did so last week around the primary care risk, as Alison's alluding to.
Okay, thank you very much. I hope that gives people confidence that the squares being circled or whatever, that it's all holistic. Okay, so I'm not seeing any more hands, so can I ask if you're happy to accept all the recommendations as listed on page 142? Yeah, nodding heads, marvellous. Thank you. And all that remains is item 12, and that's the date of the next meeting, which is the 22nd of February 2023. And Peter Burke's hand's just popped up. Peter?
Yeah, before we all leave, it was pointed out at the top of the meeting that this is my last IJB, and I'd like to thank everybody for their inclusivity for me and my role, and carers appreciate that as well. There are too many people to thank individually. One or two people stand out, and the two of them are the councillors, Julie and Lois. Another one is Sandy, who's given up a lot of his time, both within meetings and out with meetings, to talk me through the arcane methods of accounting. The unsung hero of the IJB is Karen, who has dug me out of so many holes that I've dug myself over the last 7 years, and she's done it with good grace and good humour, so thanks for that. And the last person is Gail. Gail and I have a mutual admiration society going at the moment, but I'd like to thank Gail publicly for all that she's done for carers, well above and beyond what she has to do. So yeah, thank you for that, and I wish you all good luck, particularly with NCS. I'll be watching from the sidelines, but I'll be interested to see how it goes. Well, that's it. Thank you.
Peter, thank you. You beat me to the draw. I wanted to get the agenda business out of the way before I rounded off by thanking you for your passionate and committed role on the IJB. And I know how desperately keen you are that we find someone who can fill your shoes. I think that's a big ask, but we will be doing our absolute best, and you deserve a break. But on behalf of the IJB, thank you for everything you've done to bring a hugely insightful perspective around carers' rights, carers' needs, and the demands on carers across Angus, and your national contribution as well. It's been invaluable. I've learned a huge amount from you, as have all of us, I'm sure. I'm hugely grateful, and I hope we can stay in touch once you embark on your next phase. Thank you for everything you've done. And may everyone enjoy whatever you celebrate across the season, as the wheel of the year turns and we head towards the light again after the solstice. So peace and joy be with you all. Take care. Bye, everyone.
Thank you.
Bye.
Thank you. Bye-bye.
Thank you. Bye.